Is that not unbelievable? And we're going to impart a little bit of that to you in the next 8 hours. So we're going to be busy. We have 118 years to pack into a couple of hours. So we'll go ahead and we will get started on Amy. Here in a moment, we're going to do, okay, so how do I make that whole screen? Right there. It's not a touch screen, is it? Look at me go.
And then you'll hit the presentation piece. And then if you want it to be on both of these screens, hit content to all.
Content to all.
There you go.
Yes, because I don't think they want us looking at them.
There you go.
Okay. I just have a couple of course, we are going to have CEUs for this conference. After, in the front of your notebook for you that are here, and it was in one of the emails that I sent out to everybody. If you didn't get it, let me know. I will get it to you. We will do Learn on Demand, is where you go log into to do our evaluations and our get your CEUs. Okay, so that will be done after class today. There should be instructions in your book. The Office of Continuing Credit here, Education here at UAMS is who is sponsoring it. It is how many credits? 5.7. Okay, 5.7. But you do have to attend the entire course. I think we have a couple of people that we're going to like roam in and out at some of the offsites. You have to be here and attest that you watched the entire thing to get credit. You'll complete the evaluation and the credit form at the end of the day. We're just making a disclosure that we are not basically making any money off of this, and that we have no vested interest in anything that we are talking about today, any products or anything like that. And that is for all of the speakers. Okay, so we're going to do something called Poll Everywhere. So everybody get out your phones, and I know you have them. And I want you to text CDH Education to 22333. And then I want you to tell me where you're located. I'm ready to see some of my outlying spots popping up here in a minute. Yeah. This is too fun. This is not neither what. I love this. This is our technology. This program is a combined effort between the NICU here at UAMS and Angel Center of Distance Health. And what Distance Health does is we reach out across the state to all these different places. So this is fun to look at, see where everybody is. Lots of cute stuff popping up. Is that everybody? I think they're still coming across. Somebody back there with the camera needs to take pictures of what we're doing while we're all on camera. Okay, that is fun. Lopez. Okay, so what is the small, we've got one more question and we'll move on. So what is the smallest baby you've ever seen? A is under 1 pound, B is 1 to 2 pounds, C is 2 to 3 pounds, and D is above 3 pounds. That just means one person talking. Lots of little babies. For those of you who travel in here, we're going to try to get you a tour through the units and stuff today. Okay, does everybody think theirs has come through? We are about 15 minutes behind, so we've got to catch up somewhere. Okay. Now with each of the modules, we will be doing questions at the end like that. And if you can't text in or anything, or don't have your phone, that's fine. It's completely voluntary. There's no grading on that, so it's just kind of a fun, interactive thing. Okay, we are going to start with the fetal to neonatal transition, and that is Amy Garrett. Amy's going to come to the front. Amy received her BSN from UCA in Conway, currently lives in Conway. She is our clinical program staff educator for the Women and Infant Service Line here at UAMS, and she comes to us with 9 years of UAMS NICU experience. Good morning, Amy.
Good morning.
Let me get this full screen for you. Yeah, she's going to, and you just arrow over here.
Okay. Hi, everybody. So I'm going to talk to you today. I'm going to put some water somewhere where I won't electrocute myself. I'm going to talk to you today about fetal to neonatal transition. And this is where the miracle of life and sometimes that NICU roller coaster begins. And this was a very difficult concept for me to grasp, especially as a new grad. It still kind of blows my mind when I think about it because it really is truly a miracle how the human body works. And this is something that I never really understood because it was such a hard concept for me to grasp until Dr. Ashley Ross sat down with some family and actually drew a picture and explained to them how it works. And then at that point, it's like, oh, it's like this light bulb just clicked in my head, and like, I get it now. So I'm hoping that I can do this presentation justice so I can help you guys understand it because it is a pretty complicated concept. It's a lot of information to try to pack into 45 minutes, and I'm going to do the best I can to get all this explained, but I do have some references that I can point you to for more information. And a bit of more graphic explanation and stuff like that.
Okay. What's that? I didn't know.
Technical difficulties again. Oh, I see.
Yeah. So you see what you need to see, but we can't see.
Right, okay. Bear with us
It's
just a moment.
supposed to be on presentation, so let's do instructor. There we are, okay. Student camera. And they all left. And they all left.
Oh, no. Oh,
Okay, it's right here. So then you want it to all screens. Yes, okay, there you go. No,
I hope everybody can see. Okay. I hope everybody can see this. Okay, so our learning objectives for today. The first thing is we want to describe the maternal factors that can result in a disruption in fetal development. And that's because you need to understand how that fetus developed so because that's like your patient history, right? So that whenever the baby is born and that baby becomes a neonate, you can understand what has happened to that baby up until that point, just like any other patient history. We're going to identify the 3 major organs involved in successful transition of a neonate from intrauterine to extrauterine. We're going to compare the fetal physiology of those 3 organs in an intrauterine environment to the neonatal physiology in an extrauterine environment. We're going to identify changes the fetus experiences as it transitions after it takes that first breath, what happens as it transitions to an extrauterine environment. And we're going to discuss some neonatal pathophys that you guys commonly see in the NICUs as a result of an incomplete transition. So first we're going to review our fetal concepts. So fetal development, it stops at the time of delivery, but always keep in mind that that premature neonate is still developing. So fetal development stops, but that neonate is still developing. Always keep that in mind. It consists of many critical periods which are affected by each stage of the development. It's affected by many factors. So again, this is like taking in your patient history. It's like getting the background of your patient. What has happened to your patient up until the time it's born? So you look at maternal health. Maternal hypertension affects the way the placenta provides the nutrients to the baby because of vasoconstriction. Look at maternal diabetes. That could affect the heart and how the heart is formed. It can also make the baby LGA. There's all kinds of things that diabetes does to a neonate. Mom's nutrition, whether she's malnourished or if she's got some sort of chronic comorbidities such as Crohn's disease or IBS, all that could affect the quality of the placenta and the nutrients that the fetus gets as well, and other conditions of mom. You also need to understand that the fetus is affected by external factors, exposure to teratogens, if mom's on any kind of medications, if she's taking illicit drugs, or some other environmental toxins such as cigarette smoke, that can affect, even secondhand smoke, that can affect the fetus and the fetal development as well. Continual assessment of the fetus helps determine and evaluate an at-risk fetus. So it's very important mom receive prenatal care and we monitor that fetus as it grows and develops. Premature labor or delivery will most likely interfere with that normal fetal development. So this is typically associated with pregnancy-induced hypertension, preterm premature rupture of membranes, or maternal infections. Fetal circulation. This is where it gets really difficult, and I hope again that I do this justice to explain this to you. To understand fetal circulation, I kind of want to review normal circulation first and see how that goes and remind us how the blood flows through the heart, and then I want to talk about how it's different in a fetus. So in us, as a human person outside a womb, the blood goes through the heart from the IVC and the SVC, the inferior vena cava and the superior vena cava. It goes to the right atrium of the heart, into the right ventricle. From the right ventricle, it goes to the lungs through your pulmonary artery, and that's where the blood is oxygenated. From the lungs, it goes into the left atrium of the heart, which empties into the left ventricle, which then the ventricles are the squeezers, right? So the ventricle then squeezes the blood out into the pulmonary, the heart through the pulmonary veins. From the left atrium, see, I'm getting all confused. From the left atrium of the heart through the pulmonary veins to the left ventricle. From the left ventricle, then it goes to the body through the aorta. So, in a fetus, the mom is providing the oxygenation, right? So the blood does not need to go to the lungs because mom is oxygenating. And that's the whole purpose for the blood to go through the lungs, is to grab that oxygen, right, to carry it throughout the body. So, because of that, the pulmonary veins and arteries have a higher pressure and they're constricted because your blood is going to follow the path of least resistance, right? So it's going to go systemic. So the blood flows from the placenta through the umbilical vein, through the ductus venosus in the liver. So it goes past the liver into your IVC. The majority of the blood bypasses the lungs due to that increased pressure and resistance in the lungs. Fetal lungs only need enough blood supply to actually support tissue growth and development because they're not oxygenating, because mom's oxygenating. So your pulmonary vessels are constricted. Your alveolar sacs are filled with fluid, so there's no gas exchange happening there. They're filled with amniotic fluid. That amniotic fluid causes low levels of oxygen in the blood, which also causes that vasoconstriction. So the constriction is known as hypoxic pulmonary vasoconstriction. This makes the heart find a different path, because like I said, it's going to travel the path least resistance, right? So if the pressure in the lungs is high, it's not going to try to go that way because it's going to meet that resistance. So it's going to go systemic, and that's exactly what a fetus needs it to do because the lungs don't need to breathe to create oxygen. So it's going to find a shortcut or another path to take. So the blood is going to bypass the lungs due to that increased pressure. The majority of the blood travels from the right atrium of the heart directly into the left atrium. It does not go into the ventricle. So it goes from the right atrium to the left atrium. Through this little flap, there's a septum that divides the two atrium, and there's a little flap when it's in the fetus, and it's called the foramen ovale, and it just flaps open and close like this. So the blood flows, the flap opens, and the blood goes over to the left side. Only a small amount of blood enters the ventricle and the pulmonary arteries. And again, that's just to promote tissue growth and development. Blood from the left atrium then goes to the left ventricle and bypasses the pulmonary arteries and the lungs because, again, it doesn't need to oxygenate. It goes through the ductus arteriosus, which is, I wonder if I have a pointer, which is up here. There's a little hole, and you'll hear, in layman's terms, a hole in the heart. That's your ductus arteriosus up here. So that goes directly into the aorta and out to the rest of the body. So again, bypassing the lungs because you've got that increased resistance. And then blood returns to the placenta through the umbilical artery. So your two shortcuts that this path is going to take is through the foramen ovale, and it's going to go from here to here. And then it's going to go through the ductus arteriosus, so it goes from here to your aorta out to the rest of the body. Okay. So the lungs in the fetus is very, very important in their development and the outcomes of these patients. The lungs develop in 5 stages. The embryonic stage actually starts at week 1 of the embryonic life until week 5. That's when a single lung bud develops and forms and divides. Your pulmonary vein develops, and the baby's trachea develops at that point. The pseudoglandular phase, which you can see here, weeks 6 to 16, all your conducting airways are formed. Your bronchi, your diaphragm, your bronchioles all form and develop during that stage of pseudoglandular. That's weeks 6 to 16. The canalicular phase is here, and that's week 16 to 26. This is when the formation and the differentiation of gas exchanging units begins. This is the precursor to your alveolar ducts and your alveolar sacs. So this right here is a very critical period, and if you consider how many babies are born during this time, they're not very well equipped with what they need in order to be viable. So it's right here at that point where their gas exchanging units are starting to develop. The terminal sac phase or the saccular phase is weeks 26 until birth. That's when the alveolar sacs are formed. That's when small amounts of surfactant start to be produced. Around week 26 to 28 is when the surfactant starts to be produced. And as the fetus matures and develops, more surfactant is produced. Your alveolar stage is week 32 until 8 to 10 years of age. And that's when the alveoli are proliferating and developing still, all the way to 10 years old. So a lot of parents struggle with this concept, and it is a very complicated concept, and it's hard for them to understand when their baby is born prematurely and you're trying to explain to them that they're having a difficult time breathing, and they tell you, well, my baby's been breathing, we saw him on ultrasound and my baby was breathing. Well, there's a thing that the fetus does, it's called practice breathing, and that's just so that they can exercise those muscles, because lungs are made of smooth muscle. They're just practicing to get that rhythm down. So you have to explain to them, and remember, your pulmonary vessels are highly constricted because the baby does not need to oxygenate itself. Mama's doing that for them. So pulmonary vascular resistance increases during fetal development, and that's, again, to get the blood to follow the path of least resistance, so it goes systemic. In utero breathing movements or practice breathing begin as early as 11 weeks gestation. And I thought that this was really cool, and I found this, found this ultrasound. I'm gonna see if I can get it to play. Nope, that's not gonna play. Oh, shucks. Let me see. No. Oh, well, let's get it. It played when I practiced this earlier. Oh, well. All right, so anyways, but what it looks like, and you can go on YouTube and look at it, the practice breathing, is that the fetus is actually doing that diaphragmatic movement that you see the babies that are laying in our isolettes doing, and it's actually practice breathing. So you just kind of have to explain to the parents, you know, they're just exercising. They're basically just working out. They're not really breathing because their lungs are filled with amniotic fluid. So that's what they're seeing, and it gets them really confused. So you just have to remember to explain to them what's happening there. So, fetal transition. Fetal transition is the period from when the newborn is delivered and the umbilical cord is clamped and cut, and that baby takes its first breath. That's when the transition begins from fetus to neonate. And it occurs from that moment that first breath is taken until about 6 to 10 hours after delivery. So successful transition of a fetus from intrauterine to extrauterine life is dependent on those three organs. The lungs, they're responsible for now oxygenating the neonate's blood because it hasn't had to do that before. The heart is responsible for circulating that now oxygenated blood throughout the body, and it's supposed to work a little differently now than it did inside mama. And then the brain is responsible for telling those things to do what they're supposed to do. So, I don't have time to show this video, and I really wanted to, but I'm going to highly recommend that you guys also get on YouTube and look up this Khan Academy. And it's the circulation. You can look up fetal circulation video and also the circulation right after birth. This video makes this concept so easy to understand. There's drawings and descriptions. They're about 10 to 15 minutes per video, but they're very, very helpful in explaining how all this works. So, when that cord is clamped and cut, the neonate should begin spontaneous respiration. That's what should happen. Your fetal circulation should shift to normal circulation. So your pulmonary vascular resistance should decrease because now we need the blood to go into the lungs to actually oxygenate and do that gas exchange in the lungs. So your systemic vascular resistance should increase because, again, we want the blood to follow the path of least resistance. So your pulmonary resistance, where it was high in mama, intrauterine with a fetus, it's going to go down, and your systemic is going to go up so that that blood goes in the path that it should go. Your circulation should no longer bypass the ductus venosus. The loss of prostaglandins from the placenta causes a constrictive effort on the patent fetal ducts. So those ducts, the ductus arteriosus and the foramen ovale, should close. That little flap that was flapping in utero should not flap anymore. It should stay set. You should have a definite septum between your two atria now, so it shouldn't be flapping. And your ductus arteriosus should close, and that takes a little bit of time for it to close. All right, so here's the question. Which of the following pressure changes accurately represents normal postnatal adaptation to extrauterine life? A, an increase in pulmonary vascular resistance and an increase in systemic vascular resistance. B, an increase in pulmonary vascular resistance and a decrease in systemic vascular resistance. C, a decrease in pulmonary vascular resistance and an increase in systemic vascular resistance. Or D, a decrease in pulmonary vascular resistance and a decrease in systemic vascular resistance. I'll give these guys some time. So far, everybody's saying C? Does it show, like, how many people have responded? There. I can't see that. guys are all correct. It is C. Your pulmonary vascular resistance should decrease when that baby transitions, and the systemic vascular resistance should increase. So that's correct. Okay. So now we're going to move on to difficulties with transition. And again, this is where that NICU roller coaster begins, right? So this is why we are providing our care in the NICU. Failure to successfully transition can result in the following complications or conditions that most oftentimes requires some level of care. Maybe not a NICU visit, but at least some continued close monitoring. For instance, TTN, or transient tachypnea of the newborn. This happens with babies who are usually the ones that are born C-section, that they don't get that vaginal squeeze in a normal vaginal delivery to clear the lungs of the amniotic fluid, so their lungs are still full of fluid, or your people say they're wet. So that causes the baby to be a bit tachypnic because they're breathing, because their lungs have that fluid in there. They might be grunting a little bit. They might have mild retractions, intercostal and substernal, as the fluid clears or as the fluid is reabsorbed. So to help that baby out, you might have to require some supplemental oxygen until that fluid is cleared, and or some suctioning, like the Delee suction whenever the baby's born, to help them clear their secretions. Apnea of prematurity. This is, again, when one of the organs is not doing exactly what it's supposed to do due to it not being fully developed. And again, this all goes back to the disruption in fetal development, right? So the brain has not developed fully. The neurotransmitters are not working as well as they should because they're immature. So they have immature brain development and neurologic function, which causes them to have a reduced drive to breathe. Sometimes they honestly just forget to breathe. And sometimes you have to go pat them on the little booty and go, hey, you need to breathe. And they're like, oh yeah, I have a job to do. So some signs and symptoms include apnea for 20 seconds or more, a deceleration in the heart rate to 80 beats per minute or less, and a decrease in oxygen saturation less than 85%. So these are your signs and symptoms. So the way we treat apnea of prematurity, it's like I said, that tactile stimulation to remind the baby to breathe. You know, kind of go pat them on the little booty, especially if they're laying all quiet and still and calm and in a deep sleep. You kind of have to go pat them a little bit and say, hey, don't forget to breathe. If it is a repeated instance where they're just, going apneic often, you talk to your doctor and you may have to treat it with medication. Usually we treat with caffeine, sometimes theophylline, and I don't know about you guys, but I have to have some caffeine to stimulate my central nervous system. So the baby needs a little bit of caffeine to help its brain remember, oh, I've got to do stuff. So it stimulates the baby's central nervous system. If the baby is anemic, that could cause baby to be apneic, because especially with our premature babies and we're drawing a lot of lab, we're taking a lot of blood off faster than they can create the red blood cells. So if the baby's anemic, the baby might need a blood transfusion, and that might fix it. The baby may need resuscitative efforts using the NRP steps in order to get it to resume respiration. So remember your NRP steps, remember your Mr. SOPA. Stimulate the baby, do your mask with your PPB suction, make sure there's nothing back that is not an obstructive apnea. And you may consider an alternate airway if that baby's just not breathing. Respiratory distress syndrome. This is mostly attributed to a surfactant deficiency, especially in preterm births, because remember, as we talked about, the surfactant doesn't really start being excreted until about 26 to 28 weeks. So if you have babies that are born right about that time, they don't have surfactant on board. They've barely had time to start secreting it. And so what we need to do is to help them out and give them some surfactant. So remember that surfactant reduces surface tension in the lungs and increases lung compliance, which means that's the ability for the lungs to inflate. And thereby the lungs are able to easily inflate and the baby's not having to work as hard. But if you have a lung that's very stiff, and I always think of like a dried out rubber band, right? Because it's not very stretchy and you're like, ugh. If that surfactant is not there, the lungs are not going to be very stretchy, and so it's going to be very hard for that baby to open up their airway and open up their lungs. So that way their increased work of breathing is there because they're having to work harder because their lungs aren't as compliant. So impaired gas exchange results from decreased lung compliance because if they're not taking those big deep breaths, they're not getting that oxygen and carbon dioxide exchange happening. So that leads to hypoxemia. Some signs and symptoms of this include tachypnea, moderate to severe retractions, nasal flaring, and expiratory grunting. How many of you guys have seen this? Very, very common. Very, very common. So treatment of respiratory distress syndrome, we give exogenous surfactant. We use Curasurf. We do a thing that's called Ensure. So we intubate the baby, we give surfactant, and then we extubate the baby after a certain amount of time. That way we allow that baby to get that surfactant really all in their lungs, because after you administer surfactant, typically you don't need to leave them extubated because they really just needed that surfactant. And once they have it, you can put them on CPAP or nasal cannula and they tend to do fine. So we have an established protocol here. So the RT administers our surfactant. The nurses at the bedside, our responsibility as a nurse is to monitor the vital signs and how the patient tolerated the procedure. And then when the baby is ready to extubate. So we monitor for any complications, especially from bagging. You know, the baby might have a pneumothorax if their lungs are not that compliant, and you're bagging that Curasurf down there, that is a risk of this procedure. So we do want to continue to provide respiratory support, but via nasal cannula, CPAP, and maybe even leave the baby intubated for a period of time. Antibiotics sometimes are used with respiratory distress syndrome if an infection is suspected. And again, that goes back to remembering mom's history and what happened with mom. Why did she deliver preterm? So sometimes there is an indication for antibiotics with a preterm birth as well. So persistent pulmonary hypertension. This is the one that you really need to understand fetal circulation to understand. And this is the one that was very difficult for me to grasp because the heart is so complicated and complex. But if you remember your fetal circulation, you will totally understand this. This is caused by persistent increased pulmonary vascular resistance. So once that cord is clamped and cut and baby takes that first breath, the pressures in the lungs are supposed to decrease, right? Well, in PPHN, they don't. They stay up there. So the blood is now shunting into the path of least resistance, and that's what causes this. So reasons why babies have PPHN, it could be a maldevelopment or an underdevelopment of the fetal lung tissue. Again, you need to go back to mom's history and what's going on. If there's meconium aspiration syndrome, can cause PPHN because meconium's real sticky, right? So if it gets in the lungs, it's going to decrease your lung compliance and all that. So it's going to raise that pressure in the lungs. A traumatic delivery or a hypoxic injury at birth can lead to PPHN as well. So some signs and symptoms of PPHN: marked tachypnea and cyanosis, retractions accompanied by accessory muscle use and nasal flaring, a difference in the preductal and postductal oxygen saturations greater than 5 to 10%, and that's because your blood is shunting away from your lungs. And they probably have a murmur. The only way to definitively diagnose this is by an echocardiogram, so you can watch how the blood is flowing away from the lungs. So if you suspect this, an echocardiogram would be ordered. So treatment of PPHN is usually high-frequency ventilation. It promotes adequate gas exchange. It decreases the tidal volumes that we need to provide, so that reduces barotrauma to the lungs. Surfactant therapy, especially if there's also accompanied respiratory distress syndrome, pneumonia, sepsis, or meconium aspiration syndrome. Usually inhaled nitric oxide because that makes the lungs a little bit more affinitive for oxygen. And coordination of care should be maintained to decrease the stimulation of this infant because this infant needs to be, it doesn't need to be worked up and doesn't need to be breathing faster than it should be, and more faster than the ventilator is set to be. So you really need to keep this patient on minimal stimulation if possible. So PDA is another thing that we commonly see in our NICU, and this is when the ductus arteriosus fails to close following delivery. It normally occurs within several hours or days after birth. The blood is shunting left to right. and so because you still have that hole there. So some signs and symptoms, you may or may not have a murmur with a PDA. You may have a murmur you hear 1 minute and then you don't hear it the next. Your patient will have tachypnea, will have an increased work of breathing, will have an increased oxygen requirement, will have difficulty weaning ventilator settings. And this is when their PDA is large, this is usually where you figure it out if you just can't wean that baby off the ventilator. The baby may have poor feeding or poor weight gain, and baby may tire easily. And there's different severities of a PDA. So your PDA, it could be non-symptomatic or minimally symptomatic, and that's usually they just wait for time to see if that PDA will close by itself. If your baby is symptomatic, though, there are treatments that we do. Indomethacin or Indocin is an NSAID, and it causes a pressure change within the heart. And the baby may receive up to 3 doses. You need to really monitor their labs because their kidneys could actually take a hit from this drug. So you really need to make sure that their urine output is adequate, their potassium level and their BUN and their creatinines are level before every dose. So you want to look back at what their labs were before you gave the Indocin and what they are now, and if there's any change, you need to really be aware of that and monitor that closely. There's also a increased risk for necrotizing enterocolitis, and intraventricular hemorrhage with this drug. So you need to be very careful when you're administering this. If the Indocin is not effective and the baby is still symptomatic, surgery may be indicated. If that is the case, the patient will need to transfer to a level 4 NICU for a PDA ligation. The PDA ligation would happen there, and the patient may be able to transfer back to your facility once the baby's stable. And staples and sutures are often removed on post-op day 7. Your PFO, your patent foramen ovale, this happens as a result in the defect of the heart formation itself. If you have that septum that divides your atrium, if there's a defect there, or if that flap doesn't close when the pressure changes and it's still open. So some signs and symptoms of that. The patient's generally asymptomatic. You may or may not hear a murmur. Again, you might hear a murmur 1 minute and not the next. The treatment, there really isn't a treatment for a PFO unless it is associated with another cardiac anomaly, such as an atrial septal defect. So most PFOs resolve on their own by the time the child's 2 years old. So they will be followed in the pediatric clinic just to make sure that there's no other anything else going on with that patient. HIE, or hypoxic ischemic encephalopathy. This occurs as a result of a hypoxic event during labor and or delivery. So this could happen if you have an abruption, a uterine rupture, umbilical cord prolapse, amniotic fluid emboli, overwhelming maternal blood loss or cardiovascular collapse, such as in some sort of trauma, car accident, that kind of thing. Signs and symptoms depends on the length of oxygen deprivation. If this happens in-house and you can get that baby out quickly, it's going to have better outcomes. But if this happens somewhere out in the field, like for instance a car wreck, and that baby's probably not going to have the best outcomes. So the baby will present with pale skin, weak or absent breathing, hypotonic, they'll just be laid out floppy, lethargy, and most likely seizures depending on the severity. Your treatment of HIE is definitely mechanical ventilation, anti-seizure medications, volume replacement due to the volume loss and the blood loss from mom. You can either give packed blood cells or albumin. You'd also want to do pressure support with inotropes, dopamine and dobutamine. And then if the patient is qualified, you want to do therapeutic hypothermia. And there's certain criteria that the infants have to meet for that. The body cooling has a neuroprotective effect. It slows down the brain activity and the metabolic rate. So some other causes of impaired transition. Secondary apnea. Secondary apnea is apnea that say the baby has been apneic and you do your appropriate interventions and you stimulate and the baby resumes respirations. Okay, that's primary apnea. But if you do those things and you stimulate and the baby does not respond, they're in secondary apnea and they are not going to breathe on their own. So you have to act. So many possible causes include prematurity, sepsis, a hypoxic event, traumatic delivery. You've got to do PPV and or mechanical ventilation for respiratory support because that baby's not going to breathe spontaneously. Other impaired transition causes, congenital heart disease, coarctation of the aorta, aortic valve stenosis, interrupted aortic arch, all those things could impair the transition. And again, you really need to know the history of mom and what could be happening with this baby. This is another reason why prenatal care is so important, so you can anticipate these things and treat them as soon as baby is born if possible. And then any kind of lung abnormalities, pulmonary hyperplasia, atresia, pneumothorax, and PIE. All right, another question. What is the name of the fetal shunt that is responsible for shunting blood between the aorta and the pulmonary artery? A, foramen ovale, B, ductus venosus, C, ductus arteriosus, and D, Blalock-Taussig shunt. Okay, looks like everybody's answering C, which is correct. Ductus arteriosus. The references are included in the slides as well. And again, I really want to encourage you to go watch that Khan Academy video because it's pretty awesome and explains it with drawings and everything in a way that's really simple to understand. Okay, thank you.
Oh, thank you, Amy. Good job. Okay, let's load the next group. Okay, our next segment is bereavement, correct? Misty White is going to be presenting bereavement. Any questions before we switch over to bereavement while I'm loading? Anyone have any questions? You're supposed to say, any questions? I know. Do you want to read?
You're back here. Trying to get us back on top.
Okay, did you have a question?
Yeah. On the HIE, so the procedure, is that something that they'll do forever?
Probably. It depends on the damage. She was asking about seizure activity, if that was something they were that's good. More than likely, if they're seizing then, there's enough brain damage that yes, it will be a long-term issue. And that is the one factor that usually kind of determines the outcome more than anything. That's usually a very, that you have some distinct brain damage, and it happens very quickly. Okay, I have Misty White. She is going to talk on bereavement care. Misty received her BSN from Henderson State University in Arkadelphia. She is currently our Women and Infant Service Line Bereavement Coordinator, and she comes to us with 15 years of maternal child experience. So, Amy, it's yours. Misty, it's yours.
Hey, my name's Misty. I have been at UAMS since 2008, but I've worked other places too. Came from Henderson, like she said, and also had experience in emergency medicine and at Children's also, and under Cancer Institute. So I just want to talk to you a little bit about bereavement care. So everybody's had coffee, right? Everybody awake? We have a couple of learning objectives we have to go through. Identify the Joint Commission standards when caring for bereaved families. learn grief concepts and special considerations, and then explain the standard of care with bereaved families surrounding perinatal loss. So the Joint Commission standards are here. You can see that we're supposed to focus on patient, family, comfort, dignity, psychosocial, emotional, and spiritual needs as appropriate with death and grief, and then staff is to be educated on the unique dying patients and their families and caregivers. So we want to go over these standards of care because we want, as a hospital, we want to be able to focus on the family and what their needs are in special situations. Perinatal loss is involved in many things, including pregnancy and fertility, embryonic death, spontaneous abortion, missed abortion, miscarriages. And you see here, miscarriage is pregnancy loss, now defined by Arkansas Department of Health by 12 weeks gestation. That's just recently changed from 20 weeks to 12. 15 to 20% of pregnancies end in a miscarriage, and approximately over 1 million per year in the U.S., 1 in 5 pregnancies. Fetal death, stillbirth is fetal death, now defined also as after 12 weeks gestation. In the U.S., we have estimated 2,600 deliveries result in stillbirth per year, 1 in 100 deliveries. National rates for neonatal death is 1 in 110 births, and that's from first 28 days of life and down. Terms surrounding loss or grief denotes internal and external reactions or emotions to the impact of loss. Bereavement is a situation of being deprived of a person or the object in which was valued, and mourning is the responses to which we have to that. This is just a quick little review of what these definitions are. So grief are the emotions that an individual experiences. It's very real to that person, very unique, and it depends on how the person has been taught by cultural and social beliefs and their support system. So death is a very universal experience, yet the responses to it are shaped by our cultural experiences. 5 stages of grief are denial, anger, bargaining, depression, and acceptance. And you see here, as they go through these, they're not boxed up in a tiny little box that they just are presented with. They come from all different areas of point of entries. And so with our patients, they may experience different than another patient, and they express that differently also. So it depends on where they're coming from. The grief is very real, but may look different and based on circumstances, such as prenatal diagnosis. So if they were diagnosed very early on, that they knew that they were going to be in comfort care situation or lose their baby, they may have come to acceptance of that a little sooner than if we are diagnosed immediately and we have to come to the hospital and deliver. Or you come in to hear your baby's heartbeat and there's not one. So they're going to experience that in very different levels, and they also will shoot from stage to stage and not necessarily be in order. So here's another one that kind of shows you it's not a straight line by any means. Like denial is in the first reaction. In this stage, individuals believe that the diagnosis is somehow mistaken and they cling to the false. They prefer reality. So the second one is anger. When the individual recognizes that denial cannot continue, they become frustrated, especially the proximate individuals. Certain psychological responses of the person undergoing the phase would be, why me? This is not fair. How could this happen? Who's to blame? What did I do wrong? Those type of things. Bargaining is the next one. It involves the hope that the individual can avoid and cause the grief. Usually the negotiation of extended life is made in exchange for a reformed lifestyle. People facing serious trauma can bargain or seek compromise. For instance, I'd give anything to have him back. If I could have him back, I'd stop smoking, anything like that. Then the next one's depression. Of course, this is where they become despaired over their mortality. I'm sad, why bother with anything? I'm going to die soon too, what's the point? Those type of things. and then they become acceptant. It's going to be okay. I can't fight it anymore, so I might as well prepare for it. But like I said, they're gonna bounce back and forth to different reactions with that. So you see here, this is the actual experience of grief from day to day. They may start to go down and around the cycle, and then something will trigger that loss and they'll bounce back. So supporting families. Clinicians caring for these patients and families must be sensitive to cultural and religious beliefs and the parents' wishes. You're intimately involved in creating memories with these parents that they're going to hold with them forever. They take everything very literally. They remember every name. They remember every vision that they saw when this experience happened because it's traumatic to them. And please know the many different resources in your hospital when caring for these patients. So like here at UAMS, now we have a bereavement coordinator, pastoral care and chaplaincy. We have social workers. You can also call in our charge nurses, our ADONs, those type of people will help you. Some of the smaller hospitals, your fellow nurses may be the only people that you can lean on. So just know where to turn if you need help. The role of the care provider is to provide guidance and gentle direction, effective communication, empathetic, emotional, and spiritual support. You should listen to the parents and let them explain their reason for the decisions that they're making. Allow them to tell their story and retell it again. Listen to any questions rather than making statements, and don't make judgments. Like I said, this is a serious crisis for the family, so provide appropriate interventions, with a team approach. If possible, avoid having like pregnant nurses caring for these type of patients. That really hits them hard. I've heard just through being in the support group and those type of things, that they're very angry at pregnant people at that point because it's such a hard time to go through. So that's something to think about. Provide consistent and accurate information, written and verbal, and will probably have to be repeated many times. Offering reading materials that are specific to their loss, like miscarriage or stillborn, is helpful. Explaining and offering written grief responses, also the differences in men and women and how they grieve differently helps the family. And include information that how other family members are involved in that grief. Discharge teaching should also include after pains, sexuality as normal after a loss, and then lactation experiences that they may experience. So a full-term stillborn mom may experience her milk still coming in and those type of things versus one that's early, like an early loss. And then remember to follow up. This is a key component in caring for those parents. Many of them realize the extent of their grief only after they've been discharged. So remember that we need to call them and say, hey, how's it going? We're thinking about you still. And then we should offer as many choices as we can and create as many memories as we can. So we want to use the same patient family-centered care model when we're caring for these patients. We should still provide them with consistent, accurate, and unbiased information involved in end-of-life care. We should also encourage their participation in end-of-life care as much as they're willing to, or as much as they want to be involved. At UAMS, I know that we provide care to the parents, and we say, we explain end-of-life care, and we explain that they can be involved in bathing, they can be involved in dressing. Even though we think as nurses that's real important for us to do, it's really important for them to do, because that's the first and last time the baby will be bathed. That's the first and last time it'll be dressed. And so a lot of times they want to do that care. We should listen and honor their perspectives, values, beliefs, and choices with special consideration for cultural and religious preferences. We should also allow them to make decisions when appropriate, like I said. We should, as a hospital, try to provide as much perinatal loss support by team. It's best implemented in a team approach, and try to know all your team members that are available at each and individual hospital. Here at UAMS, we have nursing, medical, bereavement coordinator, pastoral care, case coordination, patient education, Morgan Funeral Directors, and then, of course, in the center of that would be your family, your support system, and your patient. So we should all assess bereavement care, sources of support for the parents, their perception of the loss, their coping skills. Common questions that they may ask is, like I said, why did this happen? What happened? Did something I caused it? Did something I do cause this to happen? How long does grief last? What do I tell the other children? Will this happen again? Those type of questions. We should stay in tune with how they're coping and remain sensitive to their needs and help them understand that you're not being judgmental, that you're trying to help. What's important to the parents is clear communication, confirmation of their loss, guided support, involvement in making decisions, protect their baby. They want to know that their baby's comforted, that it's not going to be alone during this process, and that it's free from pain. Even if they might not want to hold their baby during this process, it's important that someone stays with the baby and holds it or cares for it while it's in the process of passing. Open family and sibling visitation, we've begun to do that quite often, just letting as many as the parents want to come back. Of course, we're all nurses and we know how to run people out, but it's real important to them to let all their family members come back if that's what they choose to do. They want to be with and hold their baby, and they want to create as many memories as possible. And we try to create as many positive memories as possible. Special considerations in grief care. Our fathers, they're kind of like the forgotten grievers. We should try to involve them as much as possible and not just let them sit aside and not involve them in decisions and those type of things. Teen pregnancy loss, they're still young. They might want to post everything on Facebook or social media. It's important that their fellow friends approve of everything that's going on, and so they'll worry about the way it looks on social media. They'll worry about, what about when I have to go back to school? What am I going to tell everybody? And those type of things. Teens are focused on themselves. They're focused on appearance and how their baby appears to others. Each year, 750,000 to 850,000 teenage women in the U.S. experience pregnancy. That's a lot. Over 500,000 of them will suffer from abortion, miscarriage, pregnancy loss. And subsequent loss is also very important. So your grief can be compiled on top of each other, like if you just lost your father and then you're losing your baby, and then, it's even more, it's largely grateful for us to be looking at compounding grief and multiple triggers that might be hurting their situation at that time. Cultural and religious considerations, the parents may be different cultures, and they may have different views on the way they want things done. We sometimes go into a room and we ask the parents, would you like the baby to be baptized or prayer or anything like that? And the dad will be like, yes, and the mom will be like, no, and then we have to come to some kind of compromise. So we can talk about what we're able to offer, and then we give them time to let them discuss what they may want to happen during, that process. Some other things, our siblings, the siblings may be young, and so they're kind of also a forgotten griever. They get pushed aside during the labor process. It's important to keep them involved and to talk about their baby. They don't really know how to express grief. They don't have the words to express grief, and they have a lack of experience, and so that can be a hard time for them. They take things literally, so if we say words like lost, they actually think the baby's lost, like they don't understand. And so we need to use words that are appropriate during those situations. They don't have much control over their lives, and they grieve intermittently, so they'll grieve for a short period of time, and then they'll go play for a while, and they'll come back and grieve again. They don't understand that the grief will go away eventually. They feel like it's here to stay, and so it's important that the parents and that we let them know that they're reassured of their physical and emotional needs at that time. And grandparents are not only grieving the loss of their grandchild, they're also grieving the loss of, or they're not able to help their child with grief at that time, so they're hurting for their child and they're hurting because they lost their grandchild too, so they're kind of double grieving. In the United States, there's between 1 and 5 million lesbian mothers, and so same-sex partners are very important for us not to assume that the couple's heterosexual, acknowledge their partner, and it's important from what research has said, the partners appreciate inclusion and making those decisions also, regardless of their gender, and we should probably try to focus on a lot of our paperwork not saying father, signature, father this, father that, maybe saying partner, significant other. So that was real important from research. And it may look different too for the NICU Comfort Care baby, and also twins. So like if mom loses one twin and the other twin's still in the NICU, it's hard for them to come back to that same place. So it may be important for us to move that other baby to a different room or a different area, because it's so hard for her to walk down the same hallway, see the same people, the same room, those type of things, really hurtful. And so we should keep in mind that they have a difficult time returning back. And comfort care is defined as individualized medical and nursing plan of care focused on the patient's comfort. It's compassionate care that is focused on comfort instead of the cure. The goals are to prevent or release suffering as much as possible, improve the quality of the infant's life while respecting the family's wishes and providing immediate relief of symptoms in the patient who is close to death. Healthcare providers should collaborate with families to reach these goals of care. Different areas of focus for comfort care include the physical comfort, of course, like pain, thermoregulation, those type of things. Environmental support, religious and pastoral support, psychological and emotional support, and then eventually bereavement support. Our nurses and doctors are really, really good about providing comfort care in our NICU. We like the parents to hold skin to skin during the process and be part of the process as much as they want to. And the last couple I've seen, they have been really, really involved, and they appreciate that we give them the opportunity to try to help make those memories and those decisions for themselves. So tips for supporting the family are listen, be compassionate and non-judgmental, honor their decisions, we should avoid cliches and never be falsely cheerful nor sad. I'm sorry is a simple question or simple statement that you can make. Is there anything I can do for you? Not saying that this is God's will, you have an angel in heaven. I understand how you feel, because every pain is different, even if you have experienced it. I've experienced it, it was over 15 years ago, but my pain's a lot different than what someone else will experience. This is the better way, you can have other children, you're so young. Those are statements that we really shouldn't make. We should allow them to be in as much control as possible, like we said, include the father and extended families, recognize the baby as a special individual. This one's really important. The parents spend a lot of time thinking of their baby's name, so we should really recognize the baby by name, not he or she in room H509 or whatever. This is very important to them to have things, remembrance cards and things with their name posted on them. Those are very important. We should be clear about our own issues on death. So like they said, social and cultural experiences will influence the grief experience. And so if you've experienced something similar, we shouldn't let our own personal issues influence our care. We should be honest and sincere. Know your limitations. Like, don't say we're going to pay for you and your family to be transported back to whatever state. We've had a couple of experiences like that where we've had to get social work involved because we have people promising things that we can't follow through with. So it's very important to know what our limitations are and don't say things that you can't really take into consideration. Encourage the family to talk about their feelings openly and anticipate needs and allow privacy and dignity. So sometimes after we've provided that initial comfort care, bereavement care, we should give them time to be with their baby alone and experience that in what way they want to, and then check on them frequently. Okay, so here's one of our questions. Ms. Loudermilk delivers a 29-week fetal demise baby girl. In responding to her loss, you know it's okay to say, "It's best that she pass now before you know her. I'm sorry for your loss. She is in heaven with the angels. You have other children. You are young." That's correct from what I see. Moving on. So special considerations that we can do for the family is offer as many choices as possible, like we said. They want to see and hold their baby. They want to spend time alone. Pastoral care, mementos and photographs, planning a memorial service or funeral, offer genetic studies or autopsy, self-transport. This is not allowed in some states, so you have to know what your state hospital regulations are on that. Here in Arkansas, they allow them to self-transport their baby to the local funeral home within the state lines. They cannot cross the state lines, and we have a special form that they have to fill out for that. And then planning a special goodbye. So we're going to talk about creating memories. Like we said, they need to be involved as much as possible. These are some things that y'all can offer at your hospitals to help with the end-of-life care. So offering special clothing. We have a large Love Lives closet at UAMS, and different people donate to our closet. We have many that donate special little gowns or smaller outfits and layettes for the families, and we try to give them choices. When I go in and talk to the parent, I usually ask the mom, maybe what her favorite color is or something like that, and offer her those choices to, oops, I don't know what happened. Tina? Lost it. Everybody stand up, do 20 seconds. Y'all can get coffee and stuff too while we're talking. They need it.
Look at that all. There's us. And I launch that. There we go.
We're going to take a short break in just a few minutes, but y'all are welcome to get up and move around if you need to. Some other things that we also offer, blankets and hats, and many different choices and colors. And you can usually find different people in your community that will donate to, your bereavement mission. There's like quilting guilds, there's different church groups, some little old ladies, everybody wants to donate in a special way. So you can tell them, kind of what you need, and they're usually willing to get it to you. Photographs are very important because these are the memories that the parents will take home with them. Here at UAMS, we offer staff or you can get a professional photographer to come into your organization. We have now Lay Me Down to Sleep options, and I know a lot of Arkansas people do, but they can't always come. Here we go again.
time for it like to time out.
Anyway, you can take photos of special events like wedding, the baby, baptism, the parents holding. It's important for them to remember how big the baby was, and so if you can get something of significance like a small bear and take a picture with that, they can remember actually how big the baby was. And we also have some groups that you can get like a brochure, a free brochure on, and some groups provide free services to these families because they've also experienced loss. And so we have like Molly bears that will send the mom a bear the same weight that her baby was, and that's real important too. And you can look that up, it's mollybears.com. We're trying to promote different groups while we're in discussion. They didn't want us to focus on one specific group, but there's usually some professional photographers, even in your area, you can call and say, hey, would y'all mind being a part of our group and coming and taking pictures or that type of thing if you don't have someone already set up to do so. And then we have staff that can take photos too. We have a special area that's kind of got some backdrops and different things, but it's real important to also take pictures with the family, with the siblings, those type of things. Parents really like to focus on, especially twins, taking pictures of the twins together, even if one's still alive, having them lay together for a while or that type of thing. It's a lot. Footprints and handprints are really important to these families. We can use different certificates or remembrance of lives. Sympathy cards, note cards, anything that you can put handprints and footprints on are good. And some facilities offer the molds. We did for a while, but it got to where when they dried and we sent them out, they were getting a whole bunch back. But you may not have that problem being a smaller facility. We also offer memory plates, which is Mamie's Poppy Plates. It's also a free service. And they also do other states besides Arkansas. They're kind of nationally known in the U.S. They offer these free to parents. They actually cost them around $42 a plate. But they offer this. They put the baby's name and birth information on it, footprints or handprints, and you just have this little form that you fill out and you just mail it in. And it's already got self-addressed stamped envelope in there, and they send it to you. They get the plate in about 6 to 8 weeks, and it's porcelain like that you see, and it's got footprints and stuff on it. So that's a good memory. And then, other places offer other things that you can do. And mementos and keepsakes are really important. Like I said, see the picture with the hands and the bear. That reminds them of how actually big their baby, was. We have gold rings, name bracelets, birthstone shells, different things that you can do just to take pictures with to help them to remember. And offering a memory box or something to put all these items in is a good thing to do. There's different places that you can just get photo boxes, and that's kind of what we've went to lately. It holds most of their stuff, and you can also put the baby's name in that little square at the front, so it's real cute. But there's different ways you can do that. And some places have boxes that people like to paint and bring to you and those type of things. We used to use some of those. Offering the family written information is very important. Here at UAMS, we have in our Love Lives room, there's parent bereavement binders. So offering them information that's focused specifically on their loss. So we can take some of that information out if they don't need it, like on siblings. If there's no siblings, we can take it out. Or put information in, like the lactation, if they're full-term stillborn, things like that. We have kind of a wall that has different things mounted on it, but we also have these binders available. Different books in reference to their loss. And then it's important to have a pulling preservation unit. This pulls the baby and preserves their physical condition. It allows the baby to remain with the family and provides them additional time. So sometimes we have the parents go up to a special postpartum floor that doesn't have babies on it because it really hurts hurts their feelings when they can hear other babies crying. So putting them away from other families or as far as you can or in a different unit is a good thing. And they can take this, it's called a cuddle cot, and they can actually take this to their room with them, and it provides time for them to spend until they're ready to let go. After the first probably 4 or 5 hours, the baby should be placed on some type of cooling blanket or unit. We have additional things that we can use whenever someone else is using the cuddle cot for the smaller babies. We've been taking some of our little caskets and putting like cooling packs underneath the blanket, and then we can switch those out every couple of hours, and that's if it's already being used, or if they're really too small to fit in there, then we can, have other options that we can use. It's important to offer genetic studies and autopsy. Genetic studies, there's several options. There's microarray genetics, and that can be ran by your pathology department, or there's like Progenity kits that we can have. I don't know what your facility might use, but there are ways to do genetic studies, and that sometimes can offer the family some insight on what might have happened. Also with the autopsy, it provides valuable medical information about the cause of death. It doesn't always define the cause of death. Sometimes it will not tell them what happened, and then sometimes it will. So it can provide guidance for future pregnancies though. We should provide information on the purpose of the autopsy, how that can be performed. There's different autopsies that they can do. There's like a visual autopsy, or they can go all the way with no restrictions into looking into kind of what happened. So we should provide them with the options that they have. And then, of course, you'll have to have a consent. Some cultures and religions discourage performing autopsies on their adherents. And so you'll have to know their cultural background and religious background. And then options for disposition. Most places basically offer cremation at a funeral service. Like I said, here in Arkansas, they can self-transport within state lines. Sometimes this saves them money. We get people from all edges of the state, and so when they go to self-transport, all the way up to the northern part of the state, that may save them $250 when we look into that. So it's important to know, call the funeral home and say, how much would that charge them if you transport all the way from Little Rock back up to the northern part of the state. Usually anywhere from $100 to $250. So that may save them quite a bit if they're willing to do so. And we have special caskets that we can place them in. And like I said, you must know your institution's protocol and the state laws revolved around that. And then, of course, documentation. If we didn't write it down, we didn't do it. So the best thing for everybody to try to implement in their facility is a bereavement checklist, and that includes step-by-step what to do if this situation happens, and that will help your nurses and your doctors and everybody kind of follow along with what's been going on, what has happened, and then what needs to happen. We have special consult orders that can be placed. Of course, you want your consents in there, any type of more documentation that you need, nurses' notes, code documentation, death notes by your doctor, and of course a death certificate. And the death certificates vary by state and by gestational age and weight. And then we want to be sure and follow up with these parents. Let them know about local support groups that are available. May include that in your written information for discharge. We want to give them support even when they go home. Answer any questions that may arise. Like I said, they don't realize a lot of their grief until they get home. And then they're like, oh yeah, I forgot to ask about how to obtain the death certificate, or when will those autopsy results be back, or who do I talk to about that? They think about those things once everything's kind of settled down. We can also assist their grief process, and we should probably follow up with them within 1 week by what research says, between 3 weeks and then 4 months. And then probably also send out some sympathy cards, like on their anniversary date, couple of weeks after they go home, and then between 6 and 10 months. So I just want you to know there's no footprint too small that it can't leave an imprint on this world. So even our tiny babies etch a special place in our heart. And if you haven't experienced bereavement care through, your facility, try to get with an experienced nurse that's been through it, and they can really help you along the way to provide that care. And then we have one more question. Mrs. Jones had a brief period of tears when she was told that her unborn baby no longer had a heartbeat and would be delivered stillborn. Soon after, she began writing down these things that needed to be done. Based on your review of the module, you know that Mrs. Jones is grieving inappropriately. She needs to be alone to come to terms with the news that she's been given. She is an instrumental
the technical difficulties have all gone away. I needed to make a statement about the last group of slides were not quite exactly what she was going on your book because we changed something at the last minute. You might find that. It's okay. Just kind of, listen up here and we'll try to get you the new ones if you need some. But there was not enough difference to repack 50. Repack 50 notebooks, so we didn't do that. Okay, we are going to get started on neonatal abstinence syndrome. And this is Rebecca Smith, and most of you in the room know her. She is our clinical services manager in the NICU now. She received her BSN from UALR, her master's from UAMS, and she's currently our clinical services manager, and she has over 30 years of NICU experience.
Yes, I am responsible for that big hunk of the 119 years.
Yeah, almost all of it. Let's do that in a little pie graph.
I know. Let's not do that. But I was at one point, y'all. I was sitting there. I was the brand new nurse, and so thank goodness neonatal abstinence syndrome was not really that present back then, or not like it is today. So we're going to talk a little bit about neonatal abstinence syndrome today. Our objectives we're going to understand the pathophysiology of it with the withdrawal. We're going to understand the risk factors and which infants we do need to score and screen. We're going to look at what are the clinical signs of the withdrawal. We want to be familiar with the Finnegan scoring. We use that here, and a lot of hospitals use the Finnegan. Some may have their own scoring system. We're going to identify appropriate non-pharmacological interventions, what you can do other than giving meds, and then we're going to look at our algorithm here of how we treat NAS. Okay, so what is neonatal abstinence syndrome? Okay, it's withdrawal from intrauterine exposure to drugs, and that can be illicit or prescription. One of the most common is opioids, and I know everybody, it's been in the news about the great opioid epidemic. It has gotten so bad that here in the ED, I know they will not give you more than a day or two worth of opiates. If you're in severe pain, you have to go to your PCP because there's just such an epidemic. When I did my clinicals at the VA, they were discussing doing the same thing because a lot of people will do doctor shopping and everything. So it's just really, over the last probably 5 to 10 years, become a real epidemic. Opioids is not the only thing that babies can withdraw from. They can withdraw from sedatives, barbiturates, alcohol, or polysubstance abuse. So neonatal abstinence syndrome happens when you cut off that supply at birth. So the mom's been doing the medications, whether illegal or legal, and then you stop it at birth, and that causes the baby to withdraw. And every baby that's exposed to drugs doesn't necessarily withdraw. About half of drug-exposed infants does. It depends a lot on when mom did the drugs, how much of the drugs she did, a lot of those things. Okay, so the incidence it's 54 to 94% of infants with exposure to narcotics will have withdrawal. Antepartum maternal opiate drug, we talked about how much it has increased in the last decade. In 2009, there were an estimated 13,539 newborns in the U.S. that were born with NAS. That is a huge number. I was able to attend a conference last year in Tennessee. They have a huge, huge problem there in Tennessee. They have like whole wings that they've dedicated just to taking care of NAS babies. It's just really sad. In 2004 to 2013, anywhere between 7 to 27 babies per 1,000 were admitted to the NICU for NAS, whereas back in 2000 to 2012, only like 5 of every 1,000. So Then we have sensible water loss. This is the loss that we can actually measure, and it usually occurs through urine or stool, so when you're doing your diaper weights. Gastric output, so this is any gastric output that you receive either through a Robogle, an OG tube, or an NG tube. Cerebrospinal fluid, so if they have a ruptured myelomeningeal, for example, and then any miscellaneous, so that they've had a surgical site, or if they have any chest tubes, they could be losing fluid and electrolytes there. So for our first example, we're going to talk about case study number 1. So baby girl Jones is a 26-week, 720-gram infant, and she has extensive bruising on her lower extremities due to breech presentation. They've started phototherapy, and she's in a giraffe isolate on humidity protocol. So if she had low humidity settings on her ventilator, that could contribute to A, insensible water loss, B, weight gain, C, desaturations, or D, rain out. Looks like everybody has chosen the right answer, insensible water loss. So in this case, she's in an isolate, and she's on humidity protocol, which will both lessen her insensible water loss, but they've also started phototherapy. So if she was on the ventilator and the ventilator was malfunctioning or not working correctly and not providing the correct humidity, it could dry out her respiratory area and increase her insensible water loss. So now we're going to talk about how you do an assessment of fluid and electrolyte status on a newborn. So the first thing that you want to look at is your maternal history. This goes back to the same thing that Amy was talking about when she was talking about the transitioning. That the maternal history affects a lot of things that go on with the newborn, and it directly affects their status and sometimes reflects it. So if the mom's had maternal diabetes, if she's taken any medications or drugs during pregnancy and or labor, so any prescribed medications, over-the-counter medications, illegal medications. If she's had oligohydramnios during her pregnancy, it could be associated with congenital renal dysfunction. So that could be an indication that you're going to have an issue with the newborn after delivery with their kidney function. And then you want to look at any newborn history, so anything relevant to your fluid and electrolyte status, and you want to identify any factors that are going to increase the incidence of congenital renal dysfunction. So if there was any asphyxia at birth, you could have an infant that was stented or shocked that could have suffered some damage to their kidneys, which could contribute to acute tubular necrosis. Or you could have an infant with posterior urethral valves. This occurs normally in males. It's actually a blockage in their urethra. It could be partial or complete, and it leads to a backup of urine into the bladder, which then further creates back pressure into the ureters and into the kidneys, which can cause an increased fluid buildup in the kidneys, which is also known as hydronephrosis. So you want to do a clinical assessment of your newborn, and the things that you're looking at in your newborn assessment that are reflected in your fluid and electrolyte status is your weight, especially if you've had a lot of different stuff going on with your patient. We almost always do serial weights. I think most places do. Even if your newborn is only there for a couple of days, you normally weigh them each day that they're there. The important thing to keep in mind is to try to use the same scale if possible. And I don't know if a lot of people know this, but the majority of the scales that we use, the big, huge ones that have the little cabinets underneath that you can put washcloths and all that stuff in them, they are actually only accurate plus or minus 50 grams. So that's kind of a big difference. So you want to make sure that you're using the same scale so that your weight isn't off just because you're using a different scale. You want to do strict intake and output. You want to examine the infant's level of consciousness. You want to look at their skin turgor, their fontanelles. Are they sunken, which could indicate dehydration? You want to look at their mucous membranes. Are they moist or are they dry? Their capillary refill, so is it delayed? If they have any edema, and then you want to look at your vital signs. So to determine any changes in your total body water, you're gonna wanna look at those serial weights. So any sudden changes in your weight usually reflect a change in your total body water. Do you also wanna think about any disease processes that could cause shift in body water compartments? So if you have respiratory distress, sepsis, or necrotizing enterocolitis, you could have shifts in your body water compartments that don't necessarily reflect a change in fluid status, but are going to indicate some other growing concerns. Next, you want to look at your laboratory evaluation. So you're going to look at your blood urea nitrogen and your creatinine, your serum electrolytes, your hematocrit, urine analysis, and a blood gas analysis. We're going to talk about each of those separately. So your blood urea nitrogen is one laboratory value that you can look at, and it's directly related to the metabolic function of the liver and the excretory function of the kidneys. So the normal lab value for a newborn is 3 to 12 milligrams per deciliter, and urea nitrogen is a waste product that's created in the liver when protein's broken down, and it normally gets filtered out by the kidneys. So if you see an elevated level, it could indicate that the newborn has been on a high protein diet, that they're dehydrated, or they're having renal insufficiency or failure. And if they have low levels, it can indicate that they have excess fluid or liver disease. Creatinine, that's the next thing that you want to look at. That's a chemical waste product that's produced through muscle metabolism, and it's excreted entirely by the kidneys. So it's directly proportional to your renal excretory function. So in a normal newborn, your levels should be very low at 0.3 to 1.2 milligrams per deciliter. So if you have high levels, it can indicate acute or chronic renal dysfunction. The next thing you want to look at is your sodium levels. This is the main positive charged ion of your extracellular fluid, and it's excreted mainly by your kidneys. So under normal circumstances, 96 to 99% of the sodium is reabsorbed. And sodium in our body helps us regulate our acid-base balance and our osmotic pressure. And the normal lab values are 135 to 145 milliequivalents per milliliter. And the next thing that we're going to talk about is potassium. So potassium is the main positive charged ion of the intracellular fluid. It contributes to intracellular osmotic activity, and the cellular concentrations are maintained by the sodium-potassium pump. It initiates and maintains cardiac and skeletal muscle contractions, and it has a major impact on resting membrane potential in excitable cells. The normal lab values are 3.5 to 5.5 milliequivalents per milliliter. Calcium is the most abundant mineral in our body. I think we all know that it contributes to our skeletal system. It's an essential component, also teeth later on in life, and our bones, obviously, which we talked about with the skeleton. It plays an important role in muscle contraction, especially cardiac muscle, and neurotransmission and blood coagulation. And the normal lab values are 7.5 to 10 milligrams per deciliter. The next thing that we want to look at is our hematocrit. So the hematocrit is defined as the ratio of the volume of red blood cells to the total volume of blood. So there's different things that can impact the value, especially at birth. So the timing of cord clamping. So did they do delayed cord clamping on the infant, or did they have to clamp right after delivery? What was the gestational age of the infant? What was the blood sampling site? Was it from a UAC? Was it from a heel stick? Was it a venous stick? And the technique used to obtain the adequate blood flow. And the normal lab values are 43 to 61%. The next thing that you could look at is a urine analysis. So there's different variables that you could look at for your fluid or electrolyte status. So your pH in your urine analysis reflects the kidney's abilities to maintain acid-base balance. Your specific gravity would indicate your kidney's abilities to concentrate and dilute the urine. Remember, we said newborns were not very good at that. And if there's any protein in their urine, it could indicate glomerular or tubular damage of their kidneys. Normally the pH is 4.5 to 8, and the specific gravity is 1.001 to 1.020. Your blood gas analysis can also be a reflection of your fluid and electrolyte status, because it reflects our acid-base balance. And normally in the body, the acid-base balance is maintained within narrow limits. Remember, some things there's a wide limits for, but not so much with our acid-base balance. And it's a complex set of interactions that occur between the pulmonary system and the kidneys that try to maintain our acid-base balance. So any alterations in our acid-base balance, so changes in our blood pH, can reflect kidney disorders, loss of body fluids through vomiting or diarrhea. So if you have one of those NAS kids who's vomiting or has severe diarrhea, or any respiratory or metabolic disorders. And normally the pH should be 7.35 to 7.45. So now we're going to talk about alterations in our electrolytes. So what happens when they get out of whack? So hyponatremia, so this is hypo, low, so low sodium, is classified as either early or late. So in early hyponatremia, it's usually seen within 2 days of life, and it's often related to perinatal asphyxia or severe respiratory distress syndrome. You have a diminished excretion of free water and an increased secretion of an antidiuretic hormone. And your late hyponatremia is usually seen after 1 week of life. It's a very common in very low birth weight infants, and it's usually related to inadequate sodium intake. And it also occurs because they're temporarily unresponsive to that aldosterone hormone. And if you have any levels that are lower than 125 milliequivalents per liter, those need to be treated. Hypernatremia, so this is your excess sodium. You want to treat any levels that are greater than 150 to 155 milliequivalents per liter. It can be accompanied by dehydration. So if you're dehydrated and you have less free water, you will have an excess of your sodium. Or if you're overly hydrated with a fluid containing sodium, you can have overhydration. And it occurs very commonly in extremely low birth weight infants due to low free water intake. So usually they're doing fluid restriction on those kids. They're trying to get that TPN packed with the nutrients they need, and there's not necessarily a lot of free water that they're receiving. Next, we're going to talk about hypokalemia, so low potassium, which is generally defined as less than 3.5 milliequivalents per liter. The serum level is an indirect measurement because remember our potassium is usually found inside our cells. And it can be caused by hyperventilation, renal losses, or gastric output. So that Rapogel output, NG or OG2. And treatment is usually with electrolyte replacement administration, so either IV replacement or PO, depending on the level of your potassium. You want to be careful if you're administrating an IV that you're getting EKG readings both before and during and after, that they're on a continuous monitor, because rapid administration can lead to fatal arrhythmias. So you want to follow your hospital guidelines for administration. Hyperkalemia, so this is potassium greater than 6.5 milliequivalents per liter. This is a life-threatening condition that needs to be immediately treated. It frequently occurs in infants less than 1,000 grams. It can also occur in those infants who are experiencing perinatal asphyxia, those infants who have been stunned at birth that have had that loss of kidney function. They will frequently not pee for a long period of time, or if they've had a major surgery, it can cause their urine output to drop off and you'll see their potassium levels rise. So there's generally several different causes. So you could have that impaired excretion like we just talked about. You could have severe acidosis, which would happen in the case of perinatal birth asphyxia, or you could have hemolysis of the red blood cells. So in the case of hyperkalemia, what you would see clinically if your patient was on a monitor is you would start to see really small P waves. So that's what happens before the drop. So they would just become smaller and smaller and smaller until you almost couldn't see them anymore. And then the T waves, which occur after, you can see get really peaked. And the higher the potassium on the infant gets, the larger those T waves get. So we want to treat this immediately. So the first thing you want to do is make sure that all potassium administration has stopped. So if you have an infant that you're starting to see these changes on your ECG, and say for example, you came in that morning and you got a report on your patient and they said that all of a sudden last night at the beginning of their shift, the urine output had greatly dropped off and they got lab values that morning and the potassium's elevated. Oh, and by the way, there's still potassium in your TPN. If you start seeing those changes on your ECG, you need to notify your physician immediately so they can write for new IV fluids. You want to make sure all that potassium administration has stopped. You want to stabilize any membranes because remember they can have fatal arrhythmias. So usually they administer intravenous calcium gluconate to help stabilize that. You're going to move that potassium from into the cells so it has less direct effect on that membrane stabilization. So you usually give IV push insulin and glucose mixed together. And you can also give albuterol as a respiratory treatment to move potassium intracellularly. You can increase potassium excretion through the use of sodium bicarbonate. And in the case of you've tried it all and nothing is working, you can do dialysis, which usually in infants is peritoneal dialysis. But in an emergency, they could also do regular dialysis, but that would have to occur at a level 4 NICU. Hypocalcemia, so this is your low calcium. So in term infants, it's defined as an ionized calcium level of less than 4.4 milligrams per deciliter. For preterm infants, it's defined as a serum calcium level of less than 7. This occurs more commonly than hypercalcemia. Some of the clinical symptoms you may see is muscle spasms or a prolonged QT interval on their ECG. It's conventionally divided into early onset, which occurs during the first 2 days of life. And it's relatively common in preterm infants, up to 90% of very low birth weight infants. In the case of perinatal asphyxia and in insulin-dependent infants of diabetic moms. And then late onset hypocalcemia generally occurs after the first week of life, and it's usually caused by an intake in dietary phosphate. So hypercalcemia is actually exceedingly rare in neonates. We don't usually see this very often. It's defined as a serum level of less or greater than 11 milligrams per deciliter, and it usually results from excess calcium administration or vitamin D administration. And treatment includes hydration and promotion of calcium excretion. So here's our case study number 2. So baby boy Smith is 2 days old and he has a history of hypoxic ischemic encephalopathy. So he had a perinatal birth asphyxia event. His urine output has been less than 2 mils per kilo per hour since birth. His lab results included a sodium level of 140, a potassium of 7, and a calcium of 8.8. So what findings might you anticipate during your assessment? So you're looking at your monitor. Would you expect to see peaked P waves, decreased or indiscernible P waves, elevated T waves, or B and C? We're seeing several different answers this time. Okay, the majority of you have it right. It's B and C. So you'd see those decreased P waves right before, and then you would see the elevated T waves after. So you'd see both of them. So next we're going to talk about alterations in fluid status. So this is your hypovolemia and your hypervolemia. So hypovolemia, it's fluid loss, so it can be either acute or gradual. And if you have a sudden loss of fluid, it can present as signs of shock. If you have a gradual or chronic loss, it's usually the result of gradual or chronic fluid loss can result in serious metabolic disturbances. So some of the causes and precipitating factors are extreme prematurity, acute blood loss, diarrhea, unreplaced losses from gastric output, medications that can cause diuresis. So this is actually, remember when we talked about caffeine and how caffeine is so good for you because it wakes you up? What else does caffeine make you do? It makes you go to the bathroom. So one of the things that it could lead to if they were getting an excessive amount would be that diuresis. Or if you have breastfeeding malnutrition. And that's because if you have breastfeeding malnutrition, they're getting poor intake, and then it just leads to this vicious cycle of poor intake and then decreased production, poor intake, further decreased production from the heart of the mom. So our clinical symptoms that we would see in our hypovolemic infant are weight loss, low urine output, decreased skin turgor, hemodynamic changes, so tachycardia, decreased pulses, peripheral vasoconstriction, and then normal or low blood pressure depending on how the infant has adjusted. If it's from a chronic loss, you may not see a change in their blood pressure. And dry mucous membranes. So how do you manage a hypovolemic infant? You would give volume, so normal saline bolus or albumin bolus. Inotropes are vasoactive medications, so that's that list over here on the right-hand side of all the different drugs. So dopamine, dobutamine, epinephrine, norepinephrine, fluid replacement, so if you have fluid losses, so if you have a chest tube or you have a Repogel and you're getting a lot of drainage from that, you should be doing fluid replacement to replace those fluids and electrolytes that you're losing. And then if you have a breastfed infant who's getting inadequate intake, they may require supplementation either with breast milk, formula, or intravenous fluids. So some of the complications from hypovolemia are excessive weight loss, tissue damage from hypoxia. If you have, you don't have enough fluid intravascularly to be circulating through your body, and you're not picking up enough oxygen, you're not delivering enough oxygen to your cells. So you can actually have tissue damage from the hypoxia. You can have impaired excretion of drugs. Remember, if you're dry intravascularly, you're not sending very much fluid through your kidneys and you're not filtering your drugs. You can have electrolyte imbalances, and if you're severely dehydrated, you can have renal failure. So hypervolemia, so the opposite of that, so excess fluid, could be acute or gradual. If you have edema, it's usually caused from the low colloid osmotic pressure. So it causes a leaking of the intravascular fluid into the extravascular space. And it's because there's increased capillary permeability from hypoxia. There's increased hydrostatic pressure, and you have impaired lymphatic drainage. Once you get all that excess fluid into the extravascular space, it's hard for the lymphatic system to pick all that up and carry it off where you can get rid of it. So some of the causes of precipitating factors are cardiac dysfunction, respiratory distress syndrome, bronchopulmonary dysplasia, perinatal asphyxia, sepsis, necrotizing enterocolitis, renal failure. If they've miscalculated your fluid requirements, so maybe they forgot to include your fluids in your flushes when they were calculating your total fluid requirements. The use of neuromuscular blockers, so for those infants who are on high-frequency ventilation, if you're having to give a lot of vecuronium to keep them sedated or paralyzed. Infants with hydrops fetalis, and infants with syndrome of inappropriate antidiuretic hormone, and that's usually associated with central nervous system infection or injury. So your clinical symptoms, you would see weight gain in your infant, especially a pretty large, significant increase. So if you're weighing your infant and you get a weight increase of more than 50 grams or more in one day, you need to re-weigh them. If you get it again, re-weigh it again. You want to get at least 3 weights just to make sure that they really have gained that much fluid. You could see a possible decrease in their urine output. You may see a lot of edema, so like this hand here, you can see how edematous and puffy it is. And then you might see some hemodynamic changes, but it's going to be dependent on your intravascular volume status. So normally you could expect to see tachycardia and increased BP if you're edematous. So how do you manage a hypovolemic infant? You want to do those daily weights. You want to be doing strict INOs. They may start diuretics to help get rid of some of that excess fluid. They may do fluid restriction, so not administer as much fluid, so they may decrease the feeding volume or decrease the IV fluid rate. But they're going to be carefully monitoring that because you also want to maintain adequate circulating volume. You want to protect skin from any necrotic injury due to edema, so if you have extremities that are really edematous, you want to make sure that you're using gel pillows under those areas so that those areas aren't getting necrotic due to the edema in those areas. I've actually taken care of several infants before that have gotten so edematous their skin has literally split and then start weeping fluid from those areas. So that's very high risk for infection. You want to do frequent assessment of your lung sounds because these kiddos can actually also have pulmonary edema. So that's not something you're going to see on the outside, but when you listen to them, they are going to sound very wet and very noisy. And you want to manage any pain that they're experiencing. So if they're so edematous that that skin is just so tight and shiny, you can imagine that that would be very painful. And I started talking really fast, so now I've gotten to the end, and here's my references. Does anybody have any questions? I don't think our lunch is due to be delivered until, oh, lunch is here. Do you have anything you need to say to our off-site people about what time to meet us back here? Oh, sorry, that would be me. I picked it up in my paperwork, sorry.
Hit my notes up.
Trying to steal it, here's that too. So I tried to take that as well.
So actually, it said lunch until 1. We could do the nursery tour during lunch, is what we could do, yes.
What did we normally do for lunch? 45 minutes? And it's now 11:30, so at 12:15 you go to training. And you just need to tell the offset people what time we're coming back. So we're going to meet back here at 1, and then we'll just get an extended lunch.
Yeah, that sounds good.
Okay.
Okay, looks like we have plenty of time, because we're not going to reconvene until 1 o'clock. But if you want a nursery tour, we have plenty of time, so we can do that. And then, so if we want a nursery tour, let's meet back over here, 12:15, 12:20, something like that. But y'all going to go eat with us probably. So we have food, Jimmy's sandwiches, amazing wraps and salads. So let the people that are gluten-free get their salads, and then if there's some left, everybody else. Because I think there's only like 10 salads. And there is a gluten-free, the diabetics are for the salads, okay? And the gluten-free can have those, and then there's some gluten-free wraps. So, but I think there's plenty. And then there's other stuff too, so for us normal eating people. What we're gonna do is we're gonna walk over to actually the Center of Distance Health, and in the back hallway there we've hidden the table so the whole world is not out there eating your sandwiches while you're in here, because that's a busy hallway. That's the college, but the OB-GYN department, so all those doctors will come through and think, hey, look, food, and we would have none when we got out there. So we're gonna go down there and eat, and then there's a little classroom that we can eat in, or you can come back over here, whichever you wanna do, okay? And there is tea and lemonade and water over there too. So you're out, the outer line sites, we can, reconvene here at 1 o'clock. Does that sound good?
Why, y'all gonna have the same symphony?
I hope it is, and just a lot of nice coffee mugs and stuff, but you have to be present to win. Let's stand there, just stay there. You have to be here to win. Okay, this is Margaret Glasgow, and where I do babies, she does big people, she does mamas. She has been at UAMS for 22 years. That's 108 plus 100. That's a lot. That's a lot. That's a lot more hours, and she's going to talk to you about A1.
I don't know if any of y'all are aware of what A1 is, the Association of Women's Health, Obstetric, and Neonatal Nurses. So we are all encouraged to become a member of some sort of professional organization. A1 is a wonderful organization to be a member of. If you are a student, you get a big discount on the membership. It is a little pricey, it's $190 a year. But for that, you get to get on their website and look at all the research stuff that they have available. You get their practice statements on all sorts of topics. So, you know, it is neonatal and obstetric and women's health as well. So there is something for everybody in this organization. You also get copies of their 2 journals. One of them is a little bit more fluffy, sort of more society-based issues, and then the other one is just strictly a research journal. So if anybody's at school or if anybody is working on a requirement for your job, like your RN4, you know, to do some research and make presentations to your fellow co-workers, A1 is a wonderful resource to get that sort of information. They also have an annual conference every year, which are fun to attend. Yeah, we just went to New Orleans for this year's. Next year's is in Orlando. So you get to go fun places for the conference, get lots of new information, kind of get re-energized to come back and go back to work and put your new knowledge to use. So awhonn.org is the website. You can go on there and peruse, and then you can do your membership online if you're interested.
And we have a local chapter with live meetings. I think we're on Facebook Live too for those that couldn't.
Yeah, I was on vacation 2 weeks ago in Las Vegas, and it pops up on Facebook Live. Hey, the A1 meeting started, so I got to. I was wandering around a mall, but I got to listen to the A1 meeting. So that's really cool. You don't have to come to Central Arkansas to be able to be a part of our local chapter. Thank you.
Thank you, Margaret. Yeah, I told her, come get your spiel in. We'll talk about that. Okay, we're going to get started on thermoregulation in the neonate. And it's ironic, I always said that I'm talking about thermoregulation and the room is either burning up hot or freezing cold when you're giving it, because it can't ever be comfortable. Okay, so on this series, we're going to talk about an understanding of the basic principles of thermoregulation. We want to increase your knowledge on the mechanisms of heat loss and production, list the signs and symptoms of hyperthermia and cold stress. Describe preventative measures to reduce thermal stress, gain basic understanding of equipment used to prevent heat loss in the neonate, and describe other conditions that influence thermal stability. So understanding the basics. The definition of thermoregulation is the process that allows the human body to maintain its core internal temperature. And the goal of this is to create a neutral thermal environment, or a thermoneutral environment, where you balance the heat loss, the heat production, the calorie use, and the calorie gain, so that baby actually has something left to use to grow at this optimal temperature. So it's a very narrow range of temperature where the infant's metabolic rate is at a minimum, so you're not using any more oxygen than what you need, and you have reduced your calorie expenditure, and that you can maintain your normal body temperature. Now, I apologize for this. You may see it better in your book, not real clear on here, But just what this is just a variety of temperatures that, for a baby's weight and hours of life. And these are ambient temperatures. These are not baby skin temperatures, okay? This is what like the ice layer of the room needs to be. So if you have a brand new, let's say 1,000 grammer that's under 1,200 gram right here, you're looking at an air temperature of 34 to 35.4 degrees Celsius to keep that baby at that proper range. Anything higher or lower, you're burning calories and you're burning oxygen. Whereas a 96-hour-old large, say 3,000 kilo baby, that bed can be down to 29.8 to 32.8. So it doesn't take as much air, warm air to keep that baby in a cool and a warm environment. And this is very, very important. Hypothermia, there was that, when I first started teaching Stable, the first edition of Stable that I taught, they had an article that came with it that was called "It's Not All About the Lungs," and it was a kind of a powerful, article, because you talk about lungs and all the diseases and all the. Look, when Amy gave her fetal circulation, I mean that looks very intense just to make that switch and what all can go on. Where you can do all that normally, and then you get cold, and it's all for naught because now your baby's sick again. So the temperature is very, very important. Hypothermia can lead to decreased systemic arterial pressure, which means your blood pressure is going to bottom out. Decreased plasma volume, so they can be hypovolemic. Increased peripheral resistance. So if you have increased peripheral resistance, where's your blood going to go? To the core. And so you're going to have decreased oxygen to your tissues that way. That's that modelly look. And you have decreased oxygenation, that's actually in your blood. So all of a sudden your O2 levels in your blood are falling and you don't have as much circulating around your system. So, and it is associated with increased morbidity and mortality. So they've talked about that when they actually will take the temperature, that 66 to 93% of the extremely low birth weight babies, these are less than 1,000 gram babies, when they're admitted to NICU are actually hypothermic. I mean, all we do, wrap them in the bags, put them in the isolates, move them over, they still can get cold. It's still very, very hard to maintain that temperature. Axillary temperature, that is our, standard way of taking the temperature. It's non-invasive, recommended for neonates. Your normal range is 36.5 to 37.9 or 99.7 to 99. That's not 99.7. That should be 98.7 or 97.7. Do you see our ranges? That's like 97.6. Yeah, and I didn't catch it, I'm sorry. That's a really tight range. Yeah, it's like 97.6 to 99.5, somewhere in that category. Anything outside of that range, you need to, either wrap them up or do whatever, fix them and then try it again. Do your intervention and then try it again, because you do not want to charge a low temperature. Not saying don't charge the low temperature, I'm saying you need to fix the low temperature, okay? You need to show that you have actually made an intervention. Rectal temperatures, I like that picture. And rectal temperatures are kind of slow to respond to changes in the core temperature. I mean, look at your little baby and look at the size of the probe that you're trying to put there. Just think about it, So you really, that is a last resort. And usually below 1,500 is not recommended to do any kind of rectal temperature on that. And of course, there's rare cases of, you can do rectal perforations, and there's a higher risk of infection with that. And nobody likes the thought of that. So the challenges we face with our little preemie babies is that, well, beforehand, they don't have to maintain their temperature. They're in mother, and they're nice and warm in there. They're usually about 0.5 degrees Celsius greater than mother's temperature. It's a nice, warm environment there. And the problem is when you're delivered into this, this mother has been pushing for a while. She's hot, she's sweaty, they got fans, they turn the air down, and all of a sudden you've got this warm baby coming through this wet area, and out there, what's going to happen? All that heat is going to evaporate off, and that baby's going to rapidly get cool. So we have 4 mechanisms of heat loss. Conduction is when you're actually touching the baby. When it's coming, it's like that is a cold, you're laying it in on a scale or something and it's cold. They're going to lose heat to that cooler surface. Evaporation is when wet surfaces are exposed to air. How I always explain this is I love a steam shower. I love to get in just turn that heat up and let it steam. But what happens when you walk out of the steam shower? Whoosh, you feel that cold air all of a sudden, and that bathroom went cold when you got in there. And that's what it is you lose from a gradient of hotter to cooler. So if you walk out of that shower hotter than the room is, and you're wet, it's rapidly going to displace out into the room. That's a little physics 101 lesson for you there. Now convection is like a convection oven. There's a fan in there, so it's blowing air. It's the air current. I feel sorry for that little baby with that. And then radiation is when you're not necessarily touching it, but you're close enough to feel how cold it is. Like a window, if you get next to an uninsulated type window, you can feel the cool from outside of the coolness of a window, but you're not touching it. That's called radiation. So we know that neonates are very, very vulnerable to the harmful effects of thermal stress. Their skin is thin, the blood vessels are close to the surface, and compared to the adults, they have about 3 to 4 times the surface area to body mass ratio, so there's lots of heat loss going on there. With preterm or small for gestational age babies, you have an even more increased risk of temperature instability. They're not able to flex and extend, and tuck in like a regular baby can. They don't have a lot of sub-Q fat, and they have an absent or decreased brown fat. And brown fat is very important. We'll talk more about that here in a minute. So preventing the damaging effects of heat loss is your significant challenge here. This is why we, have Ziploc bags and plastic wrap and all that kind of stuff really helps with that. So risk factors for thermoregulation issues would be prematurity, your small for gestational age babies, any baby with a neurological problem such as asphyxia or intraventricular hemorrhage are very hard to stabilize, any baby with an endocrine problem, cardiac difficulties, large open areas of skin, gastroschisis babies where the bowel is outside, it's very, very hard to regulate. A sedated infant because they're not moving and generating heat, and of course drug exposure increases the problem. Okay, so here's where we get to do our little interactive texting. What is considered a normal axillary temperature range for a NICU patient? That's what we just talked about a second ago. Okay, so everybody's overwhelmingly chosen B, which is 97.7 to 99.5. It's your normal axillary temperature for a NICU baby, which is basically what ours is too, averaging 98.6. So the physiology. So we have mechanisms of heat production. What can a baby do to try to produce heat when it gets cold? Or anybody, not necessarily just a baby, but any human. They will have vasoconstriction, they'll have voluntary muscle activity, they'll shiver, and you also have non-shivering or what's called chemical thermogenesis, and it's an attempt to produce heat. So your skin receptors, okay, they'll sense that this air up here is cold, and they're starting to lose heat to it. So the hypothalamus will release some norepinephrine, and it will start this vasoconstriction right here. So as these vessels constrict, they're pushing the blood out to the areas that aren't as constricted, which are deeper, the core into your core. And what happens up here? You have decreased perfusion. And so you start getting into a lot of your metabolic issues. When you have a voluntary muscle activity, movement, if a baby's just laying there and starts getting cold, what are you going to do if you start getting cold? You're going to move. You will shiver. You'll move your positions and stuff like that. But a lot of times, a preemie baby is sedated or they're weak and they can't really move them. Or you've got a big baby that's on the vent going to be tied down, so they can't move and flex and create energy. And we have shivering. Adults shiver. Term infants can a little bit. I haven't seen it very often, but it is absent in preterm babies. They are unable to shiver. So what happens there is they will, with babies that are non-shivering or have chemical thermogenesis, a big normal baby will metabolize that brown fat, which will increase heat production and increase your metabolic rate. Now you'll have your depletion of brown fat, but under normal circumstances, that's fine. Your body can deal with it. But when you have a compromised infant or a premature infant, they're going to have less brown fat and they're not going to use it efficiently. So what is brown fat? That's fine. Brown fat is an adipose tissue that contains high levels of triglycerides. So it's a big fatty area, and it's about 1.4% of the body mass of a 2-kilo baby, and its primary function is to generate body heat after birth. So, but it's very limited in preterm infants or even absent, because it really doesn't develop to about 26 to 30 weeks, and it's not replaced. Once it's gone, it's gone. And these are the areas that you'll find the brown fat in, around the neck, the kidneys, the mediastinum, and the scapula, and it just dips down into the axillary there, which sometimes you will get a temperature of 99.6 on a baby, and you'll take a rectal temperature to be 98.6. So what's that baby doing? Burning brown fat. So with a sick or premature baby versus a healthy baby, they react very differently to this. Your sick baby will increase its metabolic demands, so it's burning calories. There's decreased brown fat, so there's not a lot to burn there. They have a limited ability to respond to, so they can't shiver, and they can't move, so they can't really respond to it. And when they have, like this baby's on cannula or maybe a CPAP, if you don't have good aerobic intake, air intake, you're getting into anaerobic metabolism, and you'll set yourself up for metabolic acidosis. With a healthy baby, they're breathing, they're moving like they should, and they adapt very much better to the environment than a preterm baby does. So thermal stress. So here is our little temperature probe. It took me a second to realize how to read this. This is in centigrade. Your normal temperature, your normal range is about your 36.5 area. So anything above that, you're also burning calories, but anything below that really gets into the stages of moderate to severe hypothermia, where you will probably have a mortality if you don't correct it, or a severe morbidity if you allow it to continue for too long. So hyperthermia. Most of the time, babies do not get fevers. There's a few of the Group B strep strains that will cause fever in a baby. That's pretty rare. Most of the time, if the baby's hot, it's our fault. Grandmother's in there with 3 blankets, or the temp probe is loose and the heater is going full blast on it. But it can also, with sepsis, you get it. You will overheat with the neonatal abstinence syndrome. These irritable babies will usually get warm. Hypermetabolism, where you have a baby with a metabolic disorder, or maternal hypothermia at birth. When she's delivering. If mother has a fever, sometimes the baby will come out with a fever. And it's usually associated with poor neurological outcome if you don't treat that also. So it's not any better to be too hot than too cold. And I'm a big safe sleep proponent, and that's one thing is they're stressing is not overheating. You're letting your baby get too hot at the home. That will also can lead to a bad outcome. So signs and symptoms of hyperthermia. They're going to be irritable. They won't feel good. They'll be tachypnic or apneic. Lethargic. They'll have poor posture, hypotension, and vasodilation, because if that blood is coming out to where it's warm, so they'll vasodilate. So cold stress. So here's the signs and symptoms of being cold. You get the vasoconstriction, where the blood is going to the core to stay warm, so there's not going to be a lot out here at in the periphery, and you build up that lactic acid. You'll have tachypnea, poor feeding. Poor feeding is pretty common with a lot of disorders. A feeding intolerance where you might get it down, but it would come right back up. They're restless, irritable, central cyanosis, apnea, bradycardia, or shallow or irregular breathing. So it can actually lead to respiratory distress. So here's that poor little model leg. I hate that. That's what happens when your blood shuts to the core, and you don't leave a lot to be out here. So this right here, when you see that, that's not going to be a good oxygen exchange going on. So this, you're building your baby up. It's probably either sick or we're getting into some kind of metabolic issue. They'll be very cool. Well, the trunk is warm, and the extremities will be very cool, pale, and mottled. And when we say cool, pale, that is the Webster Dictionary look for pale and mottled. They'll have respiratory distress, that central cyanosis. This will occur when you've got some kind of severe arterial desaturation going on. It can occur with decreased surfactant production, hypoxia, acidosis, and again, if you allow that the pulmonary vasoconstriction, just like the leg constriction, you're shunning away, and you'll end up with the metabolic acidosis. So lots of issues can go with that. Now this is one of the pictures from our historic research, isn't this? Is a UAMS baby? Is that correct? Yeah, so this is back in the day. I think this is before Becky or anybody, or Becky. Okay. That's what BC is, before Becky. There we go. Before Becky. Bless his little heart. They've got his OG tube, I guess, taped up there. I would have never done that, because I was up here, what is that? Yeah, glass bottle, they had to wash the bottles, exactly. No gloves on or anything. Look at that little guy. But it's a miracle he's doing that. I mean, to be that small. So they have some neat pictures in their rooms of baby, probably from about the 50s or 60s, that was taken in our nursery. It's really neat. They'll have poor oral feeding, where they just don't want to feed. They don't have a coordinated suck. They'll have increased residuals and emesis. See the distended abdomen, see the loops on his little belly. Now, cold stress, the baby will develop hypoxia, which is low oxygen levels in the blood. In the tissue, I'm sorry. That's that little model leg we saw. That will set us up for anaerobic metabolism, which is, if you think back to Biology 101, you got your Krebs cycle and all your little ATPs. Well, without oxygen, you're not going to get those ATPs. You're going to get lactic acid, and that's going to build up as a metabolic acidosis. So, unchecked cold stress. So if you allow this cold stress to continue, you're going to start seeing signs of apnea and bradycardia. You'll have heart rate and blood pressure, or both will increase initially. They'll be very restless. They're trying to generate, a bigger baby's going to be restless because he's trying to generate heat. He's cold, he's moving around. And you can also have changes in mental status, where if they were very alert, they may be very lethargic type thing. So to rewarm a cold stress infant, you don't want to overheat them too quickly, because what's going to happen? Where's that blood going to go? Out to the periphery, and their blood pressure's going to fall, right? So you don't want to do it too fast. So you want to measure and record when you have a baby whose temp is either just born or it's out of range now. You probably want to check it about every 30 minutes to an hour, just to make sure that it's coming up like it should. So you should watch the trend on that. You don't want to rewarm them too fast, because I'll call that vasodilation, hypotension, and can actually cause seizures if it's not done carefully. So these babies, if it's cold stress and you're trying to rewarm them, they probably need to be on a monitor, on a respiratory, pulse ox or cardiac monitor. So the best thing to do with hyperthermia is to prevent it. How can we do that? So prior to delivery, here's our room. It may be the one we were in. You're going to set your room temperature in the operating room or the birth room. Look at this, 75 degrees. How would you like to be pushing in a room and it's 75 degrees? But that is what is suggested. That way the baby comes out and does not get cold. And even up to 78.8 for preterm infants. You want to be sure and pre-warm the infant resuscitation area. That means the bed, the blankets, the stethoscopes. Make sure you have extra warm blankets. They don't recommend laying them up on top of the warmer like they tend to get, but have availability of extra warm blankets, so you can immediately get rid of those wet blankets and put clean new ones under. And then when you go to scale, if your bed doesn't have one and you need to put it off on a scale, you've got a warm blanket to put it on. So anytime we give oxygen for an extended amount of time, you don't want to do just blow-by. Blow-by is good for resuscitation, but if you realize your baby is going to need a cannula or something, get them on a heated, humidified cannula as quick as you can, because that oxygen that's coming out of this wall is not heated. It's whatever the room temperature in that behind that wall is, and I'm sure it's not very warm. And of course, cover any, like to talk about the scales and the warmers and stuff like that. Make sure everything is warm. So with a term infant, you want to dry it immediately. You don't have to necessarily, remove the vernix. You can do this on mother. You don't necessarily have to take this baby over to the bed to do it. Lay it on mother's chest, and you can wrap from there. Get rid of those wet blankets very quickly, and get a hat. A hat is very, very important. For less than 29 weeks gestation, these are your little preemie babies. You're going to put them in the bag up to the neck to minimize transepidermal water loss. And you can do most of your resuscitative efforts through that bag. And we'll cut a little hole or something, to do lines or something in. And you always want to dry their head and their hair and cover with the hat. So we devoted a whole slide to the importance of the hat, the Dr. Seuss hat, as I call it. A baby's head is about a fourth of its total body length. And if you have a pregnant baby whose head is even more than that, when they have that big head, their blood, their little heads are full of blood vessels. They're very close to the surface. And they're, again, when they have thin skin and sparse hair and those open fontanelles, that all leads to increased heat loss very rapidly. So get that hat on them. So in the initial stabilization period, we use chemical mattresses a lot. Don't use, gloves filled with water or heated microwave blankets or anything like that. You want to make sure that they can be regulated. So the chemical warming mattresses would look like a giant gold warmer that you pop and you put underneath. That's great, especially when you're trying to do a procedure and you've got that baby covered with sterile drape. Your baby's this big and your drape is this big. There's not going to be any heat into the baby. So that's a great way to get the heat from underneath. Now with the giraffes and the isolate mode, you don't use those. It's not made to do that, but it's made for a pregnant woman. So after delivery, term or preterm, if they're healthy, try to cluster the care and only uncover them when you need to. Bathe them. We talk about this a lot. They used to have, they had 1 hour to get the baby transitioned, bathed, weighed, everything, and upstairs. So what would happen when they got upstairs is we were getting all these phone calls from cold babies. So-and-so just got here. He's 97 too, Well, of course you bathed him, when he went baby. So we make sure that our babies are 98.6 for 2 consecutive temperatures before we bathe them. We're not in a big hurry to. Oh, really? Oh, okay. That's neat. Just moved to that. So they don't bathe on L&D anymore. They're upstairs before they bathe. Okay. Yeah, there's a lot of hospitals that don't bathe at all. They just don't. And we bathe. Somebody asked me that question on the unit. We routinely bathe on Tuesdays and Fridays. There's not that daily bath stuff. But if your baby is spitting up, throwing up, of course you're going to clean it up. But just to give a routine head-to-toe bath, it's on Tuesdays and Fridays. I can remember Friday night in the stork's nest, and you'd have 4 babies. It's bath night. You're like, ah! Because those mothers know it's bath night. And they know when to call you, don't they? What time your baby's due and what time you're supposed to have it ready and talk to them. So if you have a chance to bathe the baby, especially a new baby and a transitioning baby, bathe it under the warmer. And then put it back on the warmer to warm up and then take it off to the side. With the sick infant, we also want to cluster our care so that we're uncovering it only briefly. You're not having to pull that plastic bag off of it continuously. And the radiant warmer here, it says 36 to 36.5, and that depends a lot on the size. Because the smaller the baby, the higher the temperature, and the bigger the baby, the lower the temperature naturally. If you stuck a big 10-pound baby under a 36.5 warmer, he's going to get hot, and he's not going to like it. He's going to let you know. So usually we'll start at about 36.5 and then go down as their temperature is regulated. And pre-warm IV fluids, I think that just means room air IV fluids, right? Yeah, you don't want the fresh out of the refrigerator, fresh from the pharmacy refrigerator stuff. So that doesn't mean put that in the hot water. It just means make sure that they're at least room temperature before you start them. Because I'm saying, we don't have an IV fluid warmer, do we? We have a blood warmer, but we don't have an IV fluid warmer. Okay, so after, there's Allison. That was, one of her babies was on the pictures, the picture, the baby picture on the wall we were looking at. And so after delivery with the preterm, you want to try to put them in, keep the top of that isolate closed. You want to initiate humidity. We start humidity on all babies, what is it? Less than 30 weeks. We'll do humidity on them. And then we have a schedule of when, if it's, 23 to 25 weeks, you wean per this, every other day or something like that. So that we have a very set way of weaning down on that humidity. You want to cluster your care, minimize opening the portholes. We have an air curtain, we have a button that you can push that's a little air curtain there, make sure that's gone. And when mother wants to sit there by the bed and touch her baby, that's great. Open one porthole and tell her to get all the way against it, to try to minimize what is being able to leak out. And that's the one button that we will let them touch on our giraffe, is that air curtain button. They all know where that button is. It's the button that will just, when you press it, it gives you a little air curtain in front of the porthole so you can open them up without too much air loss in there. And that's the only button the parents are allowed to touch. Everything else is do not touch. So the equipment that we use for room warming is, of course, a radiant warmer. You're going to set the skin temp control at 36 to 36.5 degrees. Again, the bigger the baby, the lower the temperature. And manual should only be used for short periods. If you're taking if you're just in the temp probe or you're doing something, very, very short periods, you can cook a baby really, really quick that way. Make sure that your sides are up, and that's not only for safety reasons, but also the air current that's there to give a little bit of airflow resistance. And so try to use a built-in scale if there's one available instead of taking it off onto a cold scale and back up into the bed. Skin temperature probes. These are little probes that actually attach to either the warmer or the isolate that we set the baby's temperature, and the isolate will adjust its temperature to what we have it set. Make sure the baby's not lying on that skin temp probe. That will make it think that it's warmer, and it will cool the bed off and make the baby cold. Ensure that we have a reflective disc, and what that does is that way if you have any radiant heat coming in, you're not feeling the temperature of that heat. You're feeling the temperature of the baby. And you don't want to put that temp probe over bony prominences, areas where you have your brown fat because you're burning and generating heat there, and that will make it abnormally hot, or excoriated skin, because it's usually taped in place. The best place actually to put it is over the liver, on the upper right quadrant. I love NCIS and CSI and all those shows. And so when the coroner wants to figure out how long that body's been dead, what does he do? That liver. He sticks that temp probe in the liver. So that's kind of what is a good indication of your core temperature, is that area. Where if you put it over the stomach, you're going to get the temperature of the food you just ate or the air you just inhaled. So that's probably your best places to put on that right upper quadrant. So when you have an isolate in what was called infant servo control, that's where we attach the probe to the baby, and we say we want this baby to be 36.5. And so then the bed takes over and does whatever up or down that it needs to do to keep that baby 36.5. So they're very, very easy to manage that way. I won't say very easy, but much easier to manage that way. And we'll get them quicker to a neutral thermal environment or thermal temperature. And when you use it in conjunction with humidity, it decreases the fluid requirement and electrolyte imbalances. These little thin skinned babies have a lot of fluid loss through their skin. They'll weep, especially your little big babies will just kind of weep the fluid out of their skin. And this kind of helps control that with the humidity. really, it was kind of a pronounced, for a long time, they would talk about it, but then they say, oh, you know, it's got the side effects, you know, they would call them the fuzzy babies, where they would like grow fuzz, literally from the germs they were getting in this, you know, in this wet environment. 'Cause we think of humidity, we think of bold and fuzzy growing things, right? So, but when it's controlled, especially with these new beds, we're using sterile water, it dramatically reduced the heat in the isolate. It really does. Because we don't see those super sky high temperatures that we used to see. And that's not good, because then the baby starts, once it does start warming up, then it's going to get hot really fast that way, because the bed takes a while to cool down. So humidity has really, really shown itself to me. It's proved itself. Now, some disadvantages of this is that it can mask fever. You've got, because when you take a temperature and it's hot, what are you going to do? You're going to adjust the bed. You're going to think it's the bed. You'll change the bed, you'll change the probe, do all this, and all along the baby's had a fever. So it's kind of hard to tell when that's doing. It is expensive. You know, these isolates aren't cheap. How much is a giraffe? Are they about $60,000? They're somewhere. 40,000. Yeah. It's still a nice Cadillac. You know, it's still a nice Cadillac. So yeah, it's expensive. And it requires care when opening the canopy on this. So, you know, it does have its disadvantages and its advantages. So you want to set your skin temp control at 36.5 to 36.8 on the bed, especially with the neonate, less than 1,500 grams, you would go to the higher end of that. You put your humidity on, and just monitor the baby very closely until he warms up. So confounding factors, phototherapy, we have a lot of trouble regulating temperatures in an isolate with a big baby in a phototherapy. Those babies get really hot. And then if you're unstable room temperature, in the old unit where we went to have lunch back in that area, that room had these old windows, and so it would literally be 10 degrees cooler back there by those windows than it was on the front side. And it was very hard to regulate. Back then we just had open radiant warmers. We didn't have to. If you were sick, you were on radiant warmers. The day they came in and started putting intubated babies in isolates, our heads were spinning. You know, this was a change that wasn't taken very, very lightly by the nursing staff. And it was very hard to maintain the temperatures on those babies on the back side because they had those windows. So that's why they recommend using the double-walled isolates, because you get a little bit more protection that way. Air control with an isolate. These are generally used for our larger preterm infants, the ones that we're trying to wean out to an open crib. You have a little bit more variability in the skin temperature. And you want to do that starting point based upon their gestational age and weight. Again, you can refer back to that chart. You can also, if the baby's been in the isolate on ISC for a couple of days, you can see how the temperature is kind of gone down. And when it starts to get around the 30 degrees, that baby's probably ready to come out and tolerate it. So that's what you would put your air temp on. You would just switch it. Most of the time, I'll just switch it over to what they're on that seems to be comfortable with them. But there are charts available that will show you how to do that. So when we wean our neonate to the open crib, we actually have a early weaning protocol here that we do. That we have found that it really gets them faster to an open crib. The parents love it. Now they can get in there and touch their baby without having to ask to get it out and all that. And it can lead to earlier hospital discharges. So that's a cost savings. So what we do is, if the baby is greater than 1,500 grams, we've had a nice steady weight gain over at least the last week or so. We're tolerating our feeds. We can be dressed. That's why we showed you the laundry room and the cute little clothes and stuff, because these babies will put clothes on them and we'll get them ready to come out. And after a while, you just kind of get tired of living in a white t-shirt, so it's kind of fun to get them dressed. And if you're like me, you don't have any girls to play with, you get to dress all the little girls in little cute little pink outfits. So based on the chart, you can start weaning the baby, weaning the air. And you don't want to wean it any more than 0.5 to 1 cc per hour. And of course, you can wean a large baby faster than you can wean one of your little tiny babies. You should never wean the temperature in the isolate less than 28 degrees. I always say you turn the air on, the air conditioning on at that point. So once it gets to 28 degrees, more than likely you need to pop the top of that baby. Should be able to tolerate the air temp. Okay, our next question. So what are my indications that an infant may need to return to an isolate after being in an open crib? We're having weight loss, we're feeding on a pump, we're having increased events of apnea, or B and C. That one is kind of tricky. I'm not sure. Yeah, okay, I'm doing that. A and C, yeah. Because I'm sitting here going, because B was the one I would say no. And most of you realize that they're feeding on a pump because they're not ready to bottle feed. It doesn't mean they're not tolerating their feeds. They're just not ready to bottle feed yet. But if you have a baby that is having apnea, having increased events of apnea, close the lid and see if that works. And especially weight loss. That's the number one reason we put them back in the bed is to lose weight. So other considerations, other confounding factors here. We have neurological disorders, drafts, malfunctioning isolates. A lot of times when we have a baby with temp instability, you see it kind of progressing. You have they go from changing the probe, to changing, the site, changing the bed, kind of figuring out what is going on. Make sure that you're not, that you are using your air currents, you don't have your isolate top up any more than you have to, and that you're not leaving your porthole zone, and put a hat on your baby. So we have HIE, and I'm running out of time here. Hypoxic ischemic encephalopathy. Say that one real fast 3 times. What do we do for what? Most of y'all have talked. Amy talked about that a little bit. What is the treatment we do for this? Where do we send them, and what do we do? Head cooling, yes. We send them to Children's, and they get head cooling. Actually, it's full body cooling now. They do a body blanket. What happens is that they've had some kind of a noxic injury, which means they had a cord prolapse, they had a uterine rupture, something like that, where there was a break in the blood supply and the glucose to the baby. And their brains respond very rapidly, and they can get injured very, very quickly. So it's a dysfunction of the brain. It's usually, and they show up pretty quickly. These babies, they look at different things on their scales, and they'll look at, here's some of the stuff. They have to be greater than 36-week gestation to be HIE. Their ABGARs less than 5 to 10 minutes. So we know ABGARs are very subjective. So that can't be the only determining factor. It kind of blends in with the rest of them. You have to have initial arterial cord pH of less than 7. You have an abnormal EEG, hypotonia, abnormal reflexes, absent or weak suck, and clinical seizures. And someone had asked that earlier about the seizures. That's usually a definite sign right there when you have that. What's the number one drug that we use for seizures in babies? Anybody tell me? What do we use in adults? Do anybody know what they use in adults? Phenobarb. That's what we use in babies, is Phenobarb. Ativan is not recommended for babies, but a lot of people will think Ativan, but it's not, it's Phenobarb. So what we do is called passive cooling, and these babies are kept at a core temperature of 34 to 35 degrees, and it's usually mostly like 38 hours or 72 hours or 72 hours. And then they're very slowly warmed back up to watch. And what that does is just, so all this time we were talking about the bad effects of hypothermia. This is a good effect of hypothermia. And they found this is how those kids that would fall in the frozen lakes would live. That's what it was. It slows down your processes. There's not so much circulating of the blood where it can lead to the swelling and lead to lets the areas rest, so to say, for a little while and heal. And then they slowly warm them back up and see how they do. And they have remarkable outcomes. They really do. And it's not only babies. They did, I know it's y'all were talking about the 15-year-old that had a heart attack on the football field last year. They had killed him. Okay, any questions? Do I have any questions from anybody outside or in here? You can unmute your mic and ask if you have any questions. No questions, okay. What time is it? We have, let's see, Cleveland Legislative Regulation. So we have about 10 minutes for break and we'll start back out with sepsis. Oh, I didn't introduce myself, did I? I'm 18 years of that pie chart.
Just introduce me.
Okay. We'll give a few minutes to introduce you. Sepsis, neonatal sepsis. This is Rebecca Packer. She received her BSN from UAMS and is currently a student in the graduate program. We had our first class last night. You know what, they read the syllabus and they throw everything at you. And she's currently the advanced practice partner for the NICU and has 12 years of UAMS NICU experience.
Yeah, thank you. Most of y'all here know me. I wanted to take just a second to thank y'all so much for coming to this. I know that this concept was an idea that Amy really wanted when she was in this role, and then I really wanted it when I got into this role 3 years ago, and then when Misty joined me, I said, hey, I've got this idea, I really want to do a boot camp. And she said, okay. And she took on the entire, the full weight of getting this going. And so this day would not have happened without Misty, and certainly would not have happened without our partner with Angels and the Center for Distance Health. So I just want to recognize her back there. She deserves every bit of it. So we are in the home stretch, guys. We're going to talk about neonatal sepsis, and then we've got one other presentation after this. And then I hope you've got some good questions for us, because we want to be able to address anything that maybe you were thinking about as far as the presentations were going. We know a whole bunch about a lot of things, but we certainly don't know everything. And so I know that we have y'all's emails, and we can certainly give you our emails. So if you've got things that are come up in your institution or things that you've heard about, we love to share, and we love to email back and forth about what other institutions are doing. So I've got colleagues all over. In fact, Amanda Bondurant, who's at Washington Regional, we email back and forth all the time. What are you doing about this? What are you doing about that? Neonatology is certainly not a perfect science. We're a very young profession. Okay, so we've only been recognized by the American Academy of Pediatrics since the 1960s. So we're still really trying to figure out how to take care of babies. So there's, we do things for a long time until we figure out that wasn't such a good thing to do. For example, in my short tenure here at UAMS, we've changed pulse ox limits 3 times because we wanted their brains to develop, and then we gave them all ROP, and then we want to protect their eyes, and we realized some of them were getting CP. And so now we're back to sort of a midline sat limit. So certainly not a exact science. But I'm here today to talk to you about neonatal sepsis. It's something I'm fascinated with. I like microbiology. I took a 5-hour class that started at 7:30 in my undergrad, so Nerds Unite. That was me. And this is an excellent book. It's a good read. It's not too technical. It'll give you all the basics in infection prevention. And for those of y'all that are here, or infection concepts, for those of y'all here, I've got 2 in my office. And this is a really awesome book. Infection in the Neonate, A Comprehensive Guide to Assessment, Management, and Nursing Care by Debbie Fraser Askin. And she's a big name in neonatology. She's written a lot of books. And I'm used to walking around, and so this is odd to just kind of stand back here. I'm going to try to stay here because I know they need me for the mic, so I'm going to try to stand back here, but I usually pace the room when I present. So we're going to talk today about basic principles for neonatal sepsis and categorize neonatal sepsis. There's 2 categories that you can that they fall in. We're going to talk a little bit about pathogens specifically, and some physical symptoms of neonatal sepsis, screening and lab studies, and then some pharmacology and supportive care. Not overly technical. And I'm gonna try to get to my notes, because those of y'all that know me, I'll get off on a tangent. We'll be talking about Shield and TPN at the end of it if I don't stick with what I've written. So, technical definition of neonatal sepsis is a systemic infection occurring in infants less than 28 days of life. If you've got a kid in your NICU and he's 90 days old, he's still gonna have neonatal sepsis, so it doesn't, the day, it's just a sort of a technical definition. And while the incidence of neonatal sepsis is fairly low, it's really associated with really high morbidity and mortality. Does somebody mind to shut that door for me? That'll distract me. Thank you so much. Thank you. Episodes of neonatal sepsis very costly, not only to the infant, but to their insurance company, to our institution, to the families. Okay, so it can increase a neonate's hospital stay by 2 weeks, 3 weeks if you're talking meningitis, okay, and $25,000 per episode of sepsis. So early diagnosis, prompt treatment is essential, right? Okay. There's no single definitive test, so it's not like you could draw one test, because you might think, oh, it's a blood culture. Well, if the infection's not in your blood, then that's not the one test you need, right? And early clinical signs are subtle and nonspecific, so we'll talk about that in a second too. We'll look at a slide. So you might think, well, let's just put everybody on antibiotics at the beginning. We'll just cure all of their infections, right? Well, what does that do? It leads to resistance, right? Okay, so we have to avoid just randomly putting kids on antibiotics that don't necessarily need them. So, what are some of the other ways that we contribute? So I'm really back and forth too. I want you guys to respond to me. That helps me to present. How do we contribute to antibiotic resistance as care providers? Colostrum care. Okay, very good. Oral colostrum. So the use of colostrum care is a benefit to neonates in the NICU, especially. But how do we contribute to antibiotic resistance as care providers, right? If we give the wrong antibiotic for an infection, that contributes to antibiotic resistance. If we retime that antibiotic dose, we're running late, it's a couple hours, and we just give it, that's something else that contributes to antibiotic resistance, okay? And then if we use antibiotics without an infection, that's something that contributes. So antibiotics are germs are like humans. They love to share their genes with their offspring, okay? They multiply. And if they've got genes for antibiotic resistance, they give those genes they give those genes to the bacteria that are around them. And you can kind of see that in this photo here, okay? So we've got to be diligent. At the same time, right, you never want to delay antibiotic administration just because you haven't gotten your culture, okay? So culture is not going to save somebody's life, but antibiotics will. So if you're having trouble getting your culture, you need to talk with your physician about whether or not you want to go ahead and get the antibiotics going and then continue to try to get your culture later, okay? So what are some risk factors? We've got risk factors that come from mama. We've got risk factors inherent to the baby, and risk factors that are there because they're just being cared for in a hospital environment, right? So infections during pregnancy, GBS or other bacteria colonization in the mom, prolonged rupture of membranes, which that typical definition is greater than 18 hours, okay? And then intrapartum fever or chorioamnionitis, or what we call is just chorea. Neonatal factors include gestational age and birth weight. So there's an opposite relationship to the birth weight and the gestational age. The smaller and younger you are, the more likely you are to have an infection. Okay. The fact that there's lack of structural barriers, so their skin is so immature. If you're a premature infant, you've barely got enough layers really to maintain any sort of thermoregulation or barrier at all. And then they've got an immature immune system. And they're really dependent on maternal antibodies that cross the placenta while they're inside mama. But if they're born early, then they miss out on some of that benefit, some of those antibodies that get transferred over. So they really got nothing, no immune response at birth. And then the environment, right? premature infants, central lines, okay? Prolonged mechanical ventilation, length of time on TPN. We don't feed these babies right away, which can lead to some atrophy in their guts, which can lead to increased risk of infection. And then early or prolonged use of antibiotics. So we attended an antibiotic stewardship conference last year and realized, or were taught there, that one single dose of ampicillin changes the gut flora in a neonate. One single dose. So you want to be really good steward of who you're giving antibiotics to, because that one dose might predispose them to NEC. So categorizing sepsis. Sepsis can be early onset or it can be late onset. You'll see EOS or LOS. So early onset sepsis is typically what the baby is born with. It's born with an infection, and that's why it happens in that early period. Typically they call 48 to 72 hours. One reference I was looking at said even up to 7 days sometimes in some instances they say is early onset sepsis. So they could be symptomatic at birth or shortly thereafter. And then really you're going to evaluate their risk based on those risk factors, right? The mom, the maternal risk factors, and the neonatal risk factors. Late onset sepsis generally occurs after that 72-hour mark, and it can occur at any point in the time of the neonate's life. And really affected more by our care than their inherent risk factors, okay? And then there's a lot of concern about nosocomial infections. So I kind of think about early onset sepsis as mainly what's going on with mom and baby, and then late onset sepsis is sort of some things that we contribute to. Okay, so our large impact can be on late onset sepsis. So early onset sepsis, pretty low incidence for term infants. We typically here at UAMS see a pretty high rate because a lot of times if moms are infected, then they come here for treatment, especially if they're preterm, if they're prolonged rupture. So our rates typically are a little bit higher, about 0.5 to 1.2 per 1,000 live births overall. And like we talked about, the incidence is inversely related to the gestational age and your weight. 6.4 out of 1,000 for 34 to 36 weeks. So you see just how high the incidence level increase just because they're late preterms. And then 11 to 19 per 1,000 live births for very low birth weight infants. And y'all jump in and answer, ask me questions while we're going, okay? If you think about it, that's totally fine with me. So how do these babies get their infections when it's early onset, right? You can get transplacental transmission. Okay, this is typically infections that are transferred through the blood, or you can get an ascending infection. So the mom through the birth canal has gotten colonized with something, and then that infection ends up in the uterus. Okay. Can y'all think of any infections that are transplacental? This is the audience participation portion of this program. Okay. Anybody familiar with TORCH? TORCH, so I've been in the NICU at least long enough. We used to draw TORCH titers on kids that were infected, maybe possibly infected with something that we didn't know. So TORCH stands for toxoplasmosis. O is other, or they throw syphilis and Hep B into that category. Rubella, CMV, and herpes. Typical transplacental transmission, okay? Ascending, or intrauterine infections, GBS, E. coli, Listeria, okay? Babies can also get infections from just being delivered through the birth canal. Okay, so the mom is not affected with the infection, but the birth canal is colonized with bacteria, and that baby can inhale that, swallow it in the eyes while they're delivering, batch delivery. So a couple of pathogens that we